Yes.
Yeah.
Yes, madam. So
all
happy.
the best, Rekha.
Thank you so much, madam. I need your blessings and support. Thanks, madam.
Everyone, that's the truth.
Thanks, Selva.
Ma'am, we are going live, ma'am. 3, 2, 1.
Good evening, everybody. We welcome each and every one of you who have logged in for this wonderful webinar focusing on adenomyosis. This is Module 1, Indian Fertility Society Tamil Nadu chapter and South Tamil Nadu chapter are working together, that every month we plan for Tuesday and Thursday. We have clubbed with the Foxy persons, Dr. Ashara, and under that banner we are working on adenomyosis module 1, and we have around 3 talks, 15 to 20 minutes each, at the end of which we have interaction. Subsequently, we have a panel focusing on pain management, which is a key problem in adenomyosis. So I welcome all of you to enjoy the next 1.5 hours or maybe even 2 hours of a lot of focus on adenomyosis. Chitrakala, you can move to the chairperson CV, ma.
Yeah. Good afternoon, everybody. It is my proud privilege to introduce Dr. Priya Ayyappan, who is a secretary for IFS Tamil Nadu. She is the managing director, Srinivasa Priya Hospital, Perambur. And current position, she is an executive committee member of Fertility Preservation Society of India, OXY, and ATN RCOG. And she is also a member of Endometriosis Committee of FOXY, Executive Committee member, then Secretary for Perambur IMA, Women's Wing, Secretary for Indian Fertility Society, Tamil Nadu Chapter. And more than everything, she is very, very academic and interested in fertility preservation programs, and more so she is interested in endometriosis and adenomyosis, that I could see when she was working as a endometriosis committee chair when I was a chairperson of endometriosis committee. Welcome, Priya.
Thank you so much, ma'am, for that kind words. And together, I think both our chapters will be putting forth a lot of interesting programs in the months to come. I invite Dr. Chandra Kumar. She's joining us as a chairperson for this evening's program. Madam is practicing OB-GYN for very many years, for more than 30 years. She's the Vice President of BSOG 2022-2023, and she's been the South Zone Coordinator for OXY and Infertility Committee. She's also been the chairperson of ART Committee, and it's a very proud thing to say she's been the founder EC member of IFS Karnataka State in the time period of 2019 to 2023. So as an IFS member, we're very happy to have her in this IFS webinar. And Madam is currently contesting a key post in FOXY and which committee, Madam, you're contesting for?
Clinical Research Committee.
That's fantastic. So I think we should pull you sometime in months to come for a focus on research-oriented webinar, ma'am.
Yes, sure.
My next chairperson is Dr. Selva Priya Saranan, a charming young lady and who's been really active in the field of FOXY, where she has done her contributions, and she's the secretary currently of Nagarkoil OBG Society. She's the director of Spring Fertility Feto Care Fetogene and the clinical director of the Gift Fertility and Fetal Medicine Center.
Thank you, Priya, for the kind words.
I request you to stay with us through the program, and this is going to be an interesting one. Right. So without further delay, we will go straight off to the main program. And the first talk of this evening is by Dr. Revati Sadasivam. She'll be talking to us about the newer concepts, because adenomyosis is a disease which can be really a big challenge for the patient to handle. because at each point she has different problems to deal with, and it is an equal challenge for the clinician to actually exactly zero down on the drug to give relief for the particular problem the patient has come for. And that's because we've not understood the disease in totality. And the newer concepts in pathogenesis will be updated for us by Dr. Revati Sadasivam. She is passed out her MRC OG in 2016, and she's currently a consultant at Genesis IVF Fertility Center, Erode. She's undergone her fertility training at Nottinghamshire Fertility Institute, UK. And I would request Dr. Revati to take over the proceedings and give us a brief about this particular topic.
Thank you so much, ma'am, for those kind words of introduction. Ma'am, is my slide seen?
Yes.
Yes. Okay. Good afternoon, everybody. Warm regards from Erode. First of all, I would like to thank Rajapriya ma'am for the opportunity given. It's a great honor for me to be a part of this adenomyosis module. Now, my presentation is a very short presentation about the newer concepts of pathogenesis in adenomyosis. Why are we trying to look into the newer aspects? It's just as Madam rightly pointed out, we are trying to understand the disease further well so that we are able to give the patients a very good clinical outcome. As we all know, adenomyosis is relatively a common disorder of the uterus where we identify endometrial glands and stroma within the myometrial layer. And we also find few abnormalities in the myocytes in the form of hypertrophy and hyperplasia, ultimately resulting in enlarged uterus. So what happens is these women with adenomyosis either present to us with pelvic pain, heavy menstrual bleeding, or infertility. So our primary clinical concerns are these three complaints. And being a clinician, it's a very great challenge to handle all these complaints and to give them an absolute clinical outcome. So in my presentation, I'm trying to highlight 6 important theories which explains about the pathogenesis of adenomyosis. There are n number of theories which explains the pathogenesis, but I'm just trying to highlight those 6 important theories which carries a lot of clinical evidence, and better understanding of these theories would definitely help us improve our clinical management. Now, my first theory is about the microtrauma and the role of microtrauma at the level of endomyometrial interface. The second theory is about the enhanced invagination of the endometrium basalis layer into the myometrium. The third one is about the metaplasia, that is the de novo metaplasia of stem cells. Fourth theory is about the infiltration of endometrial cells in the retrograde menstrual effluent from the serosal wall into the myometrium. Fifth one is about the induction of adenomyotic lesions by the local steroid and the pituitary hormonal aberration. Final one is about the abnormal uterine development in response to the genetic and epigenetic modifications. First, let's revisit the basics. I'm just trying to highlight those important concepts in the basic pathology and histology. I promise you that I'll not put you to sleep. I'm just trying to highlight those features which will help us to understand the disease better. Basically, the endomyometrial interface is a mucosal muscular interface without an intervening basement membrane, unlike other mucosal tissues. Relatively, the newer concept is that subendometrial layer of myometrium, which is otherwise called the junctional zone or the inner myometrium, which is primarily our key focus, because abnormality in this junctional zone on MRI imaging gives us a lot of knowledge, and it's almost pathognomic for the diagnosis of adenomyosis. Practically speaking, inner myometrium and the outer myometrium does not have a very clear distinction, but when we look into their embryological origin, histological composition, and the physiological functions differ. Inner myometrium is the layer which lies between the endometrium and the outer myometrium, and it contributes almost 1/3 of the inner layer of myometrium. Now, the embryological origin of inner myometrium is Mullerian, and it's predominantly composed of the circular smooth muscle cells, which has less contractile elements and more of synthetic function. And this is primarily concerned with the sperm transport, embryo nidation, as well as desquamation of the shed endometrial cells. So to put it in simple words, inner myometrium is predominantly concerned with female reproduction, and our primary concern is the inner myometrium. Now, when we're talking about the outer myometrium, the embryological origin is mesenchymal. It is predominantly composed of the longitudinal smooth muscle cell, and it has more of contractile elements, and it's predominantly concerned with the parturition contractile property. So when we look into the physiological function of the inner myometrium, we expect cycle-dependent variations to happen in the inner myometrial contractions, both in terms of amplitude and frequency. During the early follicular phase, there is an increase in amplitude of and frequency of peristalsis to promote the shedding of the desquamated endometrial cells. Whereas while we travel through the cycle towards the mid-luteal phase, we expect these peristaltic movements to come down in frequency and amplitude, mainly practically speaking, so that we do not interfere, so that the endometrium, the inner myometrium does not interfere with the embryonidation process. The inner myometrium is well endowed with both estrogen and progesterone receptors, which indirectly conveys that this layer is completely under control by the ovarian steroid hormones. This is the reason why it plays a very important role in female reproduction. Now, this is the normal expected physiology and the histopathology that we should be aware about. Now, let's see what goes upside down or what goes abnormal in a woman with adenomyosis. Now, let's see about the first theory which explains the pathogenesis of adenomyosis. This is relatively an older concept, which all of us are quite aware, that there is an abnormal invagination of endometrial basalis layer into the myometrium. What we all know is that there are few cells, especially the stromal fibroblast in the layer of endometrium, which is trying to breach the already iatrogenically damaged junctional zone or an intrinsically abnormal junctional zone. And these endometrial basalis cells are trying to invaginate into the myometrium, which subsequently undergoes transdifferentiation to form the adenomyotic nodules. In support of this hypothesis, are the clinical observation that adenomyosis is quite common in women who undergo recurrent sharp endometrial curettage, repeat cesarean section, and any form of uterine surgery. The next concept is about the endometrial cell migration. As we were already discussing about, we know that there is something abnormal at the level of endometrium, and these abnormal endometrial cells have a very high invasive capacity, which are trying to go through the already breached or an intrinsically abnormal junctional zone. But at the same time, there is some abnormality even at the level of myometrium, which has been proven by this theory that the myocytes of adenomyotic individuals, they promote the augmented invasion from the endometrial cells. So now the problem is not just at the level of endometrium, even the myocytes favor the augmented invasion from the endometrial component. Now, the relatively newer concept is the collective cell migration process. This is a process of coordinated migration of an entire group of cells, wherein these cells maintain their cell-to-cell attachment, and this is commonly encountered in the physiological process of wound healing. This is a process which is expected to happen in the later phases of cellular invasion, especially in cases of severe diffuse adenomyosis. Now, this is relatively a very important theory in the pathogenesis of adenomyosis. It's not only because of the migratory property of the endometrial cells that adenomyosis develops, it's also because of the uncontrolled or upregulated proliferative capacity of the myocytes, and it's also because of the improved or prolonged cell survival. Indirectly, it means that the apoptosis is not happening at the physiological rate. There is some genetic aberration which brings down the process of apoptosis, and there is prolonged cell survival. The molecular aberration which contributes to this pathogenesis is the reduced caveolin gene expression, which results in uncontrolled proliferation of the myocytes. At the same time, there is reduced apoptotic process. Now, myostatin, follistatin, and activin A gene expression is too much upregulated locally at the level of adenomyotic nodules, which also contributes to the increased proliferation rate of these myocytes. Now let's talk about the next concept in pathogenesis. It's about the dysregulation of extracellular matrix. As I was already mentioning before, the endometrium alone is not at fault. These endometrial cells, they have higher invasive capacity, but at the same time, the myocytes also favor the augmented invasion. The reason is explained by this theory. There is a gene called the LOX gene, which is actually responsible for the connective tissue networking. But what happens in an adenomyotic individual is that the LOX gene is downregulated. So the connective tissue networking is quite loose. And this is the reason why the myocytes are getting easily invaded by the highly invasive endometrial cells. Now, this is another concept called the epithelial to mesenchymal transition. Many times we identify endometrial stromal fibroblast within the myometrium. But there are certain conditions, in certain cases, we do identify epithelial, endometrial epithelial component as well. And this has been explained by this process. It's called EMT, epithelial to mesenchymal transition. And this is actually an estrogen dependent process, which makes the endometrial epithelial cells highly invasive, and it imparts a very metastatic phenotype to these cells. And this explains the migration of these endometrial cells from the endometrium into the myometrium. Then now the next one is the microtrauma concept of the endomyometrial interface. Now this junctional zone is primarily the zone of utmost importance. What happens is there is continuous microtrauma at the level of the endomyometrial interface. This is basically because of the hyperestrogenic environment at the level of the eutropic endometrium of these adenomyotic individuals. So there is continuous cyclic hyperperistalsis. It's not the normal peristalsis. There is continuous hyperperistalsis, which contributes to the microtrauma of the endomyometrial interface. So this had been well proven by another concept. Of course, we do believe that multiparous women commonly encounter adenomyosis, but we also do encounter nulliparous women without any kind of previous uterine surgery presenting to us with severe forms of adenomyosis. This had been explained by this concept of microtrauma by hyperestrogenic environment. So what we are convinced is that it's not only the physical trauma which results in the development of adenomyosis, but also physiological trauma, otherwise called the microtrauma at the level of junctional zone, can contribute to the pathogenesis of adenomyosis. And this microtrauma is predominantly triggered by the hyperestrogenic environment. Now, tissue injury and repair, this is relatively a fancy concept, and almost all of us are quite aware and convinced with this concept. Because of the hyperestrogenic environment and continuous hyperperistalsis, there is tissue injury. So what happens is this tissue injury releases or activates the interleukin-1, which causes COX-2 cascade activation. So as an ultimate result, there is release of this prostaglandin E2, which stimulates or activates these two enzymes, the STAR enzyme and the aromatase enzyme. So what ultimately happens is there is aromatization of androgens to estrogen. So ultimately there is more of estrogen. So now our understanding is that this estrogen, actually, it has a dual effect. One way, it tries to repair the tissue damage via the estrogen receptor beta, but this effect is little insignificant. Now, the same estrogen also tries to bring about more of hyperperistalsis, more of microtrauma, and it is trying to bring about more and more of tissue injury via the estrogen receptor alpha. So this becomes a vicious cycle. Estrogen by itself induces tissue injury, activates the cascade, and it is also trying to repair the tissue damage via the estrogen receptor beta. So this gets to be a vicious cycle. So this is a simple flowchart which explains the concept of tire mechanism. Next, then we started encountering adenomyosis, not just in women with functional endometrium, but adenomyosis is also seen in women with non-functional endometrium. So that led to the question, how? This theory explains how it happens. It's because of the de novo metaplasia of the embryonic stem cell remnants. They are the embryonic epithelial progenitor cell remnants, which undergoes transdifferentiation, undergoes de novo metaplasia, and ultimately develops into adenomyotic lesions in the later part of life. Now, these two theories are also actually a continuation of the previous concept. They are the embryonic stem cell theory and the adult stem cell theory. Whenever the Mullerian duct develops and whenever there is fusion, there are few embryonic tissue progenitor or the remnant cells which are left behind or misplaced into the myometrium, which later on gets transformed or undergoes differentiation to develop into adenomyosis in the adult womanhood. And we are quite aware that endometrial stem cells have a pluripotency. So these stem cells also acquire the potency to transform, to migrate into the myometrium, which later on undergoes proliferation and transdifferentiation, which triggers the myocytes hypertrophy and hyperplasia. When all of us were concerned only about the inside to outside invasion, that is from the endometrium to myometrium. Now, Chaperon et al. Was the only person who gave us this unique concept of outside to inside invasion, which he means that even in the retrograde menstrual effluent, there are too many pluripotent endometrial stem cells which can actually invade or infiltrate from the level of uterine serosa to get into the outer myometrial layer and subsequently differentiate into intramyometrial endometrial implants. Now let's look into the genetic and the epigenetic concepts as well, because we are quite convinced that these women with adenomyosis, they have a lot of genetic or molecular aberrations. Now, the ones of prime importance are the COMT gene polymorphism and estrogen and progesterone receptor gene polymorphism, because these have been predominantly identified in Asian population. When we are talking about the epigenetic changes, the DNA methylation process is altered, which ultimately results in uncontrolled cellular proliferation. And it's not only about the immune response, inflammatory response, or the genetic epigenetic changes. Adenomyosis pathogenesis, there's a role even played by the ovarian and the local steroid hormonal aberration, which can contribute to the pathogenesis of adenomyosis. The first one of prime importance is the upregulation of this aromatase enzyme. So this causes aromatization of androgen to estrogen. So there is too much of estrogen, especially E2 in the microenvironment. And the next thing is that there is downregulation of this enzyme, the 17 beta hydroxysteroid dehydrogenase enzyme. So what happens is the conversion of E2, the potent E2 to the less potent E1 is being disturbed, because this is the enzyme which is responsible for the conversion of E2 to E1. E2 is a biologically potent form. Estrone is relatively a less potent form. So there is too much of estrogen because of the upregulation of aromatase enzyme and reduced estrone formulation because of the downregulation of this hormone, this enzyme. And ultimately, we are aware that the progesterone receptors also undergo gene polymorphism, which results in progesterone receptor resistance. Finally, there is deserialization abnormality, and this explains the reason for recurrent implantation failure or even early miscarriage in a woman with adenomyosis. So these two concepts have a very high therapeutic impact, especially when we are dealing with a woman with infertility issues. Now, it's not just the effect of the local or the ovarian steroid hormones, even the pituitary hormones have a role to play. Women with adenomyosis have been identified to have a high level of prolactin, which has been documented that there is clinical improvement with the vaginal administration of bromocriptine. Similarly, there is quite a convincing role played by the oxytocin, especially with regards to the microtrauma concept. Now, the hyperestrogenism induced hyperperistalsis and microtrauma is actually exhibited via the oxytocin receptors. And that's the reason why the severity of adenomyosis have been positively correlated with the density of the oxytocin receptors. Though they've been predominantly identified in the layer of outer myometrium, but they do have their presence even at the level of inner myometrium. We are quite aware that adenomyotic individuals have abnormality both at the level of humoral and cellular immunity, the predominant reason being HLA gene antigen polymorphism. And similarly, they have a very high inflammatory response. There are n number of inflammatory mediators which have been upregulated in these adenomyotic individuals, but the ones of prime importance are interleukin 1, 18, and tumor necrosis factor alpha. Apart from these inflammatory mediators at the local level in the adenomyotic lesions or nodules, we also find increased expression of these nuclear factor kappa beta chain enzymes and even the corticotropin releasing hormone. Now, we're also concerned about the neuroangiogenic factor because there is even upregulation of the nerve growth factor, which contributes to the neuroinflammatory process, and it explains the reason for the high intensity of pelvic pain. The other thing that we are much concerned about is that there is even dysregulation of the implantation associated factors, especially the OXA10, leukemia inhibitory factor, and matrix metalloprotease 2. All these are combinedly contributed by the altered immunoresponse, high inflammatory response, and the neuroinflammatory process. And there is even the progesterone receptor polymorphism, which results in progesterone receptor resistance. And finally, it causes impaired decidualization. This ultimately results in early implantation failure and even early miscarriage. So this is a simple snapshot for your take-home message, which explains the various concepts in the pathogenesis of adenomyosis. The older concept was only about the de novo metaplasia and the invagination theory. But recently, the microtrauma, the tire mechanism, the outside to inside invagination, the adult stem cell theory, and even the embryonic stem cell theory is finding much more importance. These are my reference slides. I've taken a lot of references, but these 6 papers are primarily my reference papers. I have gone through a lot of papers by Sylvia et al., who has given an elaborate study about the pathogenesis of adenomyosis. If you wish to know more about the molecular aberration, there's the n number of papers by Sylvia et al., and it gives us clearly about how the molecular aberrations bring about various impact, and he's given a lot of papers about the recurrent implantation failure and early pregnancy miscarriage in a women with adenomyosis. So thank you all so much for your patient listening. Hope it found some meaning. And over to Priya ma'am, Rajapriya ma'am.
Revati, I must say that was definitely a very difficult topic to pull off, considering that we all had our dreaded moments in MBBS when we had to handle pharmacopathology, right? So I pushed you back into the same phase of medicine. However, the complexity of the pathogenesis reflects in the challenges we feel in effective medical management. So I guess because so many components are evolved and being evolved, we are finding it difficult to give the right management, whether to deal with the pain or even abnormal bleeding. So during your reading, did you see a lot of link between adenomyosis and endometriosis coexisting with each other?
Yes, ma'am, especially when we are talking about the molecular aberrations, whatever I was highlighting, all these genes or polymorphisms are quite common for both endometriosis and adenomyosis. Though we consider both the condition to be an independent disease, when we consider the genetic molecular response or even the epigenetic changes, they share a lot of things in common, which explains their high inflammatory response. And especially when, I mean, a lot of papers ultimately explains us why there is recurrent implantation failure and early miscarriage in these women.
And was there any light thrown on whether it being a diffuse involving the whole uterus, and that's when it's uniformly enlarged, and at times you'll have that focal adenomyotic picture. Was there any particular relation or particular pathogenesis involved in it? Local
it just says the grades or the graduality of the progression of that endometrial invagination, ma'am. It depends on their susceptibility. However, is their myometrial connective tissue network. If it's quite loose, this invagination process is quite, it happens at a very easy pace and they get to evolve into diffuse adenomyosis. But if this connective tissue network of the myometrial layer is quite strong, that is, it is all decided by the LOX gene, their connective tissue network, which ultimately decides. Because the endometrial invagination is quite common for everybody, but the receptivity or the threshold of their myometrial connective tissue network decides whether they develop up to 1/3 of inner myometrium, or is it the whole of the outer myometrium? Is it diffuse or if it's local? Because even in the local adenomyotic nodules, there are so many molecular aberrations which are being exhibited.
Thank you. So like Ukraine, you can fight back and not allow the whole place to be invaded. So thanks for all those, taking all those questions very sweetly. I request the next speaker to come in, Revati, unless we have more questions. Anyone else? Selva, Priya, you want to ask any questions or shall we move forward?
Let's keep the questions to the end
Rekha,
because the chat box will be anyways coming. We'll be having questions in the chat box also.
Fine.
Thank you, ma'am. Thank you.
Hello.
Rekha, ma'am, you're audible.
Yeah. Thank you, Dr. Rajapriya, for giving me, and Dr. Ramni, madam. Thanks for your august presence here, and thank you so much for giving me opportunity here. Happy to be the chairperson in this such a valuable, esteemed event on the theme based on adenomyosis. Now it's my proud privilege to introduce Dr. G Padmashri. Dr. Padmashri is a sonologist at the Rao Hospital, Coimbatore since past 28 years. She's one of the key members of the Assisted Reproductive Technology team of Rao Hospital. She's presented a poster on monoamniotic twins in IFFS Germany in 2020. She's presented poster on 3D ultrasound and power Doppler in prediction of IVF outcome, ISHRE 2015 at Lisbon. She's also the coordinator of infertility workshop at UA Foxy in 2018. Also, she was a coordinator for ultrasound workshop in the same conference. So basically, her prime area of interest is sonology combined with the ART. Over to Dr. Padmashri.
Thank you for the nice introduction.
Thank you.
Very good evening to all of you. First of all, I would like to thank the organizers for giving an opportunity to talk on New Year imaging insights. There is a change in the paradigm. There is a change in the epidemiological scenario of adenomyosis. It's no more a disease of multiparous 40 years old who present with pain and menorrhagia, but more and more we see adenomyosis in younger women who present not only with AUB and pain, but also they present with infertility, and in 33% of adenomyotic patients are quite asymptomatic. So imaging techniques play a great role in identification of adenomyosis. There is prevalence of adenomyosis in relation to RPL in 38% cases.
Sorry to interrupt, ma'am. Your slide is not in the slideshow mode, and the slide is not moving also, ma'am. Can you please stop share and share once again, ma'am?
Yeah. Now is it visible?
No, ma'am. No, ma'am.
Not yet, ma'am. Not yet.
Not yet. You repeat the entire procedure, then put it to slideshow. That's all. Yeah, now make it slideshow. Now it is visible, but we need slideshow.
Now is it visible?
Not in slideshow mode, ma'am. Ma'am, please stop share and please click share screen.
No, she's already
click on the screen, ma'am. The icon should be clicked on the screen icon and then share.
No, she has shared the screen. Only she should make it to the
no, ma'am. It will not come, ma'am, at that sometimes.
It will come. She has not tried, no, that. She has never done that.
Now is it okay?
Ma'am, can you please go to the slideshow mode, ma'am?
Exactly. That's all what you should try now first.
No, ma'am, it's not
Here,
done,
down, right, you try, down, right.
Now is it visible?
Volume.
No, ma'am, no, ma'am. You need to stop share. You're clicking the icon, ma'am. You need to click screen, ma'am. Share screen, then share. That's it, ma'am.
No, down also there is a button for the end, make it the full screen. That also she can try.
Now visible?
No, ma'am.
Just 1 second.
Ma'am, you do that first what you did now. The same thing you do, the same steps.
Now is it visible?
Yes, ma'am. Yeah.
Yes, ma'am. Perfect, ma'am.
Sorry for the disturbance and delay. First of all, I would like to thank the organizers for giving an opportunity to talk on New Year imaging insights. There is a change in the paradigm of the epidemiological scenario of adenomyosis. It's no more a disease of multiparous 40 years old who present only with menorrhagia and pain. More and more, we see adenomyosis in younger women who present not only with AUB pain, but also they present with infertility, and in 33% of the cases, it is asymptomatic. So ultrasound has a great role to play in identifying the adenomyosis. As far as prevalence is concerned, adenomyosis is associated with RPL in 38.2% of the cases. In 35.1% of the cases, it is associated with endometriosis, and with the DIE, it is 50%. On top of it, if you see, 34.7% of previous ART failures are associated with adenomyosis. So diagnosis becomes all the more crucial. So you can see the normal endometrial cavity by 3D coronal view. In case of adenomyosis, there is abnormal invasion of the endometrial glands across the junction zone into the myometrium. This evokes inflammatory response, resulting in myohyperplasia, muscular hypertrophy, and the accumulation of hemorrhage inside. So this results in increased myometrial thickness, and these result in specific sonographic features. So these sonographic signs act as tools to identify adenomyosis. Strikingly, you can see this is an enlarged uterus, globular uterus, and you can see the linear striations extending from the inner myometrium to the serosa. If you look carefully, there is ill-defined endomyometrial junction and myometrial cysts. On cine, you can see the linear striations over there. So this is a heterogeneous echogenicity is a striking feature of adenomyosis. Sorry, slide. Oh. The next marker of adenomyosis is asymmetry of the myometrium. So because of the muscular hypertrophy, there is increased myometrial thickness. Subjectively, you can see the ratio of anterior and posterior myometrium being altered. If the ratio is more than 1, that is a marker of adenomyosis. And wherever the endometrial gland is there, it is depicted as an echogenic area. So endometrial gland is present in the outer aspect of the endometrium. It is depicted as echogenic spot. And 3D image shows the echogenic bud over here. And this is a rendered image where, because of the endometrial infiltration, there is an echogenic spot and bud here. So this again is a marker of adenomyosis. And when the endometrial gland settles in the myometrium, it starts accumulating the blood, and in that case, it becomes a myometrial cyst. And it could be anechoic or low-level internal echoes or with ground glass echogenicity. When you have difficulty in identifying the myometrial cyst, you can decrease the zoom, increase the zoom, or decrease the gain, and it will be lined by the echogenic rim. So you can note the number of the cysts and also the size of the cyst. So this will be very useful for the follow-up of these patients. So when the endometrial glands accumulate and aggregate, it becomes a nodule. You can see the echogenic nodule here. There are multiple echogenic islands, and you can see the 3D image with the echogenic nodules over there. And here you can see the echogenic islands. So this could be a specific indicator of adenomyosis. And you can see the 3D coronal view, and you can see the large area of adenomyosis with multiple sonographic features. And we can see the rainforest appearance because of the endometrial gland, which throws the echogenic linear striation, and alternatingly, you can see the hypoechoic muscular area. This fan-shaped shadowing is typical of adenomyosis, and it can help to differentiate from a myoma, where there is a capsule and it results in a H-shaped shadowing. And again, coming to the Doppler, in case of adenomyosis, there is translesional vascularity across the adenomyosis, and because the pathology is amid the myometrium, it is dispersed throughout the myometrial tissue wherever the adenomyosis is there, and the vessels are of smaller diameter. And contrastingly, you can see the myoma here, and because of the capsule, there is a circumferential flow. Again, this is a differentiating factor between the adenomyosis and myoma. In this recent meta-analysis with 8 pooled studies, it says 2D TVS carries 83% sensitivity, whereas 3D ultrasound carries even more higher sensitivity of 88.9%. So for all the sonographic features we have seen, The heterogeneous myometrium carries 86% specificity and myometrial cyst 72%. So whenever we see a myometrial cyst, think of adenomyosis. More the number of ultrasound features, less will be the reproductive outcome. So you can, if there are 4 sonographic features, the pregnancy rate comes down from 42% to 22.9%. And if there are 7 sonographic features, the pregnancy rate comes down from 42 to 13%. Coming to the types of adenomyosis, you can see the diffuse adenomyosis here. So wherever you see adenomyosis, we have to see the take the largest diameter. Here all the 3 uterine layers are involved, inner, middle and outer myometrium. And more than 50% of the myometrial involvement is there. So this is a severe type of adenomyosis. And here you can see the anterior myometrium showing heterogeneous echogenicity with ill-defined endomyometrial junction. So this is a diffuse adenomyosis. And again, whenever there is a dilemma, you see a large uterus here. And if you follow the uterine cavity line, it traverses through the lesion. As you see it here, this is a 3D image. In case of adenomyosis, you can see the cavity getting traversed through the lesion. Unlike in myoma, where the cavity is pushed to one side in most of the cases. And what is focal adenomyosis? You can see the circumscribed area of altered echogenicity. Focal adenomyosis is one where more than 25% of the surrounding lesion is covered by the normal myometrium. You can see the focal adenomyosis here, but quite a good amount of normal myometrium. So this is called a focal adenomyosis. So why should we attach significance to whether it's a diffuse adenomyosis or a focal adenomyosis? This is an article from Japan. It says, due to increased inflammation and high intrauterine pressure in women with large lesions of adenomyosis, the miscarriage rate in second trimester and the cervical incompetency rates were higher in pregnant women if the lesions, if the adenomatic lesions are more than 60 millimeter. So diffuse adenomyosis compared to focal adenomyosis is associated with a poor pregnancy outcome. And the prevalence of diffuse adenomyosis is more. It is in 81.7% cases, whereas focal is only 18.3% of the cases. So compared to focal adenomyosis, diffuse adenomyosis always shows a enlarged uterus. So what is adenomyoma? Adenomyoma, you can see the adenomyotic lesion, and it is surrounded by the echogenic hypertrophic myometrium. This identification is useful, especially in case of a surgical intervention. So we have to map the lesion, whether it is focal or multifocal, whether it is superficial or diffuse, whether it is diffuse asymmetrical or symmetrical, whether it's an adenomyoma, if it's a solid, cystic or submucous or subserous, whether it's an anterior adenomyosis or it's a posterior adenomyosis. So coming to form of presentation, adenomyotic intramuscular cystic lesion here, and typically because of the endometrial glandular rim, it is echogenic. And here it's another case where you can see the circumscribed lesion, cystic lesion with internal echoes because of the hemorrhage. So once identified, surgical excision will be of help. And coming to another form of adenomyosis, that is the polychordal adenomyosis. You can see the anterior diffuse adenomyosis here, ill-defined endomyometrial junction. If you see the thickened endometrium, if you see the 3D, it very well demarcates the polychordal adenomyosis here. So once diagnosed, histoscopic intervention can restore the endometrial receptivity in such cases. And coming to the focal adenomyosis of the outer myometrium, that is foam. As Chapran et al. Described, there is from outside to invasion, outside to inside invasion theory, where there is migration of the endometriotic cells across the serosa. If it is through the anterior myometrium, it is anterior form. If it is through the posterior myometrium, it is posterior form. As you can see, there's an endometriotic cyst here. There is migration of the endometriotic cells across the posterior surface of the uterus, and there is a focal adenomyosis of the posterior myometrium. This is called posterior form, and here you can see the anterior myometrium showing multiple cysts here, and with adenomyosis, this is an anterior form. And again, in case of adenomyosis, the important sign is the question mark sign. You can see the uterus here, the endometrial cavity And it is typically looking like a question mark because the uterus fundus is retroflexed and pulled back because of the adhesion. And if you see the sliding sign, it is negative. That means the serosa of the fundus is involved. There is adherent uterus. So once you see the question mark sign, it carries a higher specificity of 93% and sensitivity of 75%. Coming to the internal and external adenomyosis. What is internal adenomyosis? You can see the endomyometrial junction. Instead of a well-defined one, you can see the irregularity of the endomyometrial junction. On top of it, you can see the echogenic spots over there. So this is typical of the inner adenomyosis or internal adenomyosis. Whereas here you can see the outer myometrium showing the multiple cysts with adenomyotic areas. This is called external adenomyosis. And this is another interesting case, that is juvenile cystic adenomyosis. This is the uterus here, and subseriously it looks like a fibroid, but because it's a cyst, because there is acoustic enhancement, and there is a content is internal echoes. And if you see the 3D image, you can see the cavity here beautifully. So the congenital anomaly of accessory horn is ruled out. And if you put the HD-like image, you can see the cystic mass over the surface of the uterus. So on laparoscopy, on incision, it confirms the diagnosis of ACUM. You can see the chocolate material pouring in. And the newer modality of investigation is phonoelastography in adenomyosis. And when the elastography is applied transvaginal ultrasound, you can see the myoma picking up a blue color that shows firmness of the tissue. Whereas in case of adenomyosis, there is varying echo texture of the myometrium, so that blue, yellow, and red colors are depicted. And Akas et al. Says it carries a sensitivity and specificity of 89 and 82% respectively for the diagnosis of adenomyosis. And coming to the most important aspect of adenomyosis, that is the junctional zone. Junctional zone, this is the missing link between reproductive disorders and major obstacle disorders. You can see the normal endometrial halo around the endometrium here. This is the junctional zone. But the disadvantage is it does not show very clearly the lateral myometrium and the fundal aspect. You can see the 3D coronal view. You can see the fundal aspect of the junctional zone and also the lateral aspect of the junctional zone very clearly. So here, this is the junction zone here, and this is a hormone-dependent area, and this is a highly specialized zone because it governs a lot of reproductive function. And junctional zone, it varies with the phase of menstrual cycle. As you see, as the proliferative phase goes on, the junctional zone thickness also increases. And deep learning based junctional zone quantification using 3D ultrasound, by applying artificial intelligence, it actually delineates and demarcates the junctional zone, and it can also assess the junctional zone thickness. So in the coming years, maybe we will be seeing the machines incorporated with artificial intelligence to assess the junctional zone thickness. So how do we quantify the junctional zone? You can measure the junctional zone in the cross section, in the sagittal section, and also in the coronal section. So what is the criteria for diagnosing adenomyosis? By applying BCI image, you can clearly identify the junction zone as it is depicted here, and you can measure the thickness. If the junction zone thickness is a maximum of more than 8 mm, or if the junction zone thickness of maximum and minimal difference is more than 4 mm, or if the junction zone ratio of more than 50%, it is diagnosed as adenomyosis. So junction zone difference of more than 4 mm and the junction zone infiltration and distortion had high sensitivity, says experts et al. So as discussed earlier, the tissue injury and repair results in repeated cycles of autotraumatization, and this affects the implantation. And when the endometrial glandular involvement occurs due to microtrauma, you can see the focal infiltration of the endometrial glands in the junction zone here. And here you can see the diffuse infiltration of the junctional zone. And this is the normal well-defined junctional zone here. So you can make out the difference between the normal and the junctional zone abnormalities. So because of defective myometrial spiral artery remodeling, which happens at the basis of an altered presentation. So defective presentation results in case of an adenomyosis in the junctional zone. You can make up the difference. This is a normal pregnancy, the villus spaces, and you can see the decreased diameter resulting in decreased blood flow. And this results in SGA babies, FGR, preeclampsia, and there is increased risk of preterm birth, PROM, cesarean section, and postpartum hemorrhage. So we understood the quantification of the junctional zone. Coming to the morphological assessment of the severity in adenomyosis. And you can see we have to identify whether junction zone is irregular, as you see it here, or interrupted. Here you can see the junctional zone. One part is not at all seen. It is occupied by infiltrated by the endometrial gland. And again, you can see the cavity itself is not visible, completely obliterated. So this grades the severity of the junctional zone abnormality. So once identified, it is very helpful in counseling the patient and also to decide the management protocol in these patients. And this is an interesting case. And at the outset, you can see the large uterus here and with a diffuse symmetrical adenomyosis. And if you measure the volume, uterine volume, it is 149 cc. After 8 months of medical treatment, you can obviously see the difference in the size of the uterus. It has come down from 149 cc to 105 cc. And this is the time the Mirena loop was removed and FET was done. She conceived a singleton and she went up to 38 weeks and delivered a healthy 3.1 kg. And antenatal period was quite uneventful in spite of the prior adenomyosis in this patient. So this substantiates the theory. In a retrospective study by Zio et al., it showed that after Gnrh analog suppression, uterine volume, if it is more than 98 cc, was found to be associated with a higher miscarriage and lower live birth rates with no difference in implantation rate. In another study by Zhu et al., the average uterine volume reduction from 180 to 86 cc after 2 to 6 cycles of medical suppression gives a IVF-ET results compared to the tubal controls. So the uterine volume before embryo transfer can be used as a guide to plan ultra-long suppression before ET. And MUSA consensus group brought out sonographic classification and reporting system for diagnosing adenomyosis. So we have to mention about the location, differentiation, and uterine layer involvement and extent of the adenomyosis and also the size of the adenomyosis, because the reporting system should be reproducible and reliable for clinical documentation. So to conclude, TVS is the first test in the diagnosis of adenomyosis. Visualization of typical sonographic features will lead to lesion detection. 3D ultrasound evaluation of junctional zone for irregularity and infiltration can detect early adenomyosis. Both a higher-end ultrasound machine and high level of expertise will optimize the diagnostic accuracy. Thank you for the patient hearing.
Yeah. Thank you, madam, for your nice presentation. A little bit feedback from my side or added information, if I can say that. One thing I would like to say is that the probe tenderness itself, like when we put the probe itself, that especially when it is a diffuse adenomyosis, that patient gets the tenderness, that should give us one sign in the mind that it may be an adenomyosis just before you start the scan itself. And the second thing what I would like to say is regarding the obstetric aspects, it is the abnormal presentation, as you said, is absolutely fine. That gives 2-3 kinds of problems. Like if you can extrapolate, it's like the placenta accreta, because of the demarcation is not there. And especially when it is a global involvement of the entire uterus, the patient may have the postpartum hemorrhage because the uterus does not contract. So these are the things, other than the miscarriage, one has to keep in mind. Another important catastrophic event is the accidental hemorrhage. We have seen few cases with adenomyosis going in for pregnancy and then resulting in catastrophic accidental hemorrhages. So these are the things I would like to add. Is there any role of MRI according to you in case of as a modality, or
whenever it is associated with other pathologies like fibroid or endometriotic cyst, and the large uterus can give hindrance to the diagnosis by ultrasound. So in those cases, definitely MRI will be beneficial.
Okay. Otherwise, the routine 2D would suffice if we open our eyes and do it a proper, honest scan, isn't it, ma'am?
Yeah.
Okay. The answer, I mean, your slides on the junctional zone in detail was quite an interesting one, because it adds a lot of information to our clinical decisions. Thank you.
Thank you.
So shall we move to the next topic of this session? Okay. Now we have our very own Ramani Devi madam, and it's always a pleasure to introduce madam, because it's so easy. You just need to say her name and everybody would be knowing her. But in spite of it, she's here to talk to us about reversal of adenomyosis and the promotion of fertility. If you see its topics of today, it's been very carefully chosen. And this whole month, we are going to be dealing adenomyosis in 2 modules. So to know about Ramani madam, we know about her extensive work in FOXY, and especially when it comes to a particular topic, we know about how much she's contributed to endometriosis. So now we are going to have the doyen of endometriosis talk to us about adenomyosis too. So if you see her, she's the managing director of Ramakrishna Medical Center and Janani Fertility Center. And she's won almost 10 golden medals during her UG and PG periods. No wonder about that. And she's the winner of Professor C.S. Don Prize for 2006, 7, and 13 as primary author. And recipient of various awards and innumerable number of papers and journals to her credits. So we are looking forward to hear from the President of South Tamil Nadu IFS, our very own Ramani Devi madam, on reversal of adenomyosis and promotion of fertility.
I'll start sharing my screen.
Yes, madam.
Hope my screen is visible.
Yes, screen is visible.
Yeah.
Yes. Yes, madam. Perfect.
Okay. So I think my previous speakers have given a very good insight about the pathogenesis. Dr. Revati Sadasivam, she has done it extremely well, followed by Dr. Padmashri, who has done has given a very clear-cut idea about imaging and mainly about the junctional zone and its impact upon the fertility. It has made my job very easy. So now the topic I chose was how to reverse adenomyosis and promote fertility, because all of us know a patient with adenomyosis has got a poor fertility outcome, and even if she conceives, she has a lot of problems during the antenatal and intrapartum and postpartum period. I bring you greetings from Trichy, and you can see on the beautiful river Kaveri with and the Uchipilayar temple, and you have the UNESCO heritage, that Srirangam temple with the beautiful sculptures. So adenomyosis and infertility, what is the association? That is rather poorly understood, but by the recent emerging concepts in newer concepts in pathogenesis and imaging modalities, I think we are able to gain more knowledge about how infertility occurs in adenomyosis. And again, the presence of adenomyosis in young women and associated endometriosis are proven to be the cause for subfertility. Because previously, when we were students, we used adenomyosis was found to be the only in the decade of 3rd and 4th decade, and it was said that it is very common only in multiparous women. Now we know that its association with endometriosis and the origin of mesenchymal origin from outward to inward spread of the endometriosis, that is spread of the adenomyosis, that is especially in the rectovaginal, from the rectovaginal septum, there is migration of the tissue or the cells into the posterior uterine wall that will form focal adenomyotic areas. So that is more common in women who have associated deep infiltrative endometriosis as well as endometrioma. Coming to the mechanism of infertility in adenomyosis, mainly one is about the intrauterine anomalies. Second one is abnormal uterine peristalsis, about which Dr. Revati has in detail explained, and abnormal archimetra, and altered endometrial receptivity. Again, at the molecular level, there is abnormal receptors. There is severe progesterone resistance. There is hyperestrogenic environment. And again, there is altered steroid metabolism. Then abnormal inflammatory responses are all seen. So there is increase in cytochrome P450 aromatase, estrogens, prostaglandins E2 that may lead to uterine hyperperistalsis, which has two consequences. One is it alters the tubal sperm transportation and alteration of the embryonic implantation. Altered endometrial function and receptivity and gene dysregulation of endometrial proteins like HOXA gene and FOXA gene, all the other genes are abnormally seen in this adenomyotic patient. There's again abnormal concentration of intrauterine reactive oxygen species. The increase in production of all these things could explain there is increased risk of preterm delivery, mainly because of hyperperistalsis. Again, PPROM, and again, all placental complications what the previous speakers are explained. There is also higher incidence of placenta previa, placenta accreta, and all these things can happen even when they become pregnant. So let us take one by one. Intrauterine abnormality. Anatomical abnormality due to adenomyoma, where the cavity is totally altered. There may be jetting of the adenomyotic lesions into the posterior wall or wherever there is, altering the entire cavity. And this can lead to obstruction to the ostia that interferes with the sperm migration and embryo transport. Distortion of the uterine cavity again interferes with implantation. So there is altered uterine peristalsis, which starts from the junctional zone, and invariably the outer myometrium is quiet. But whereas the abnormal junctional zone in adenomyosis causes abnormal uterine contractions, and in turn that increases the intrauterine pressure. So there will be involvement of injury to that of the endometrium, which will be pushed into the myometrium because of abnormal hyperperistalsis. Increase in junctional activity prior to embryo transfer is often associated with decreased pregnancy rate and increased incidence of ectopic pregnancy also. I don't want to go about this much because Dr. Revati has clearly explained there is increased interleukins, COX-2, prostaglandin, and cytochrome P450, and then there is steroidogenic acute regulatory protein as being abnormal, and which will lead to increased 17-beta estradiol, which causes hyperperistalsis, leading to uterine trauma. There will be fragmentation of the endometrial tissue that will get implanted into the myometrium and forms adenomyotic lesions. Or it can go through the transtubal spill and it can cause endometriotic lesion also. There is destruction of normal archimetra. See, we must understand the myocytes of normal uterus are quite different from that of the myocytes of the adenomyosis. And the junctional zone shows cellular and nuclear hypertrophy, abnormal nucleus, mitochondria, and abundant myelin bodies. These increase in the myelin bodies are responsible for the hyperperistalsis in turn. Again, there is altered calcium channel transport leading to abnormal rhythmic contractions affecting the uterotubal transplome. Altered endometrial function and receptivity is the most important one that leads to abnormal implantation. There is abnormal endometrial metabolism, increased uterine oxidative stress, impact implantation. So there is again altered steroid metabolism, which has been dealt in detail, increased cytochrome P450, and then increased local E2 production. There is again suppression of 17-alpha beta hydroxy steroid dehydrogenase enzyme system. So the conversion of E2 to E1 is failed, and there is piling up of the active component of estrogen, that is the E2. So that again, this treatment with Gnrh analogs and danazol, they decrease the expression of P450 and aromatase expression. So looking into the abnormal inflammatory responses, patients, they have a great stromal macrophage density, and the macrophages are capable of producing all sorts of pro-inflammatory factors like tumor necrosis alpha, interleukin 1, 6, messenger RNAs are overexpressed, then long non-coding RNAs are there, and interleukin 10, increased nitric oxide, ROS, and cytokines. So all these things are getting a negative impact and on sperm transport, implantation, and residualization. So this is what happens in the utopic endometrium, but what happens in the adenomyotic lesion? See, in utopic endometrium, there is always down regulation of this leukemia inhibiting factor, interleukin level, and then in the utopic endometrium of adenomyotic patients, OXA10, integrin B, and OPN, but whereas there is increased expression of NO, SOD, catalases, VEGF, MM2, then interleukin 10 and P450. But in the adenomyotic lesions, again, few of them which have been suppressed, like leukemia inhibiting factor and interleukin level are suppressed, and there is elevation of all these pro-inflammatory factors. So we have two important gene expression, that is HOXA10 gene expression is suppressed, that will lead to altered endometrial receptivity and poor implantation. FOXA1A is another gene that is responsible for proper residualization. Again, this is downregulated, leading to poor residualization. At the receptor level, we have certain abnormalities like overexpression of estrogen receptor alpha, what Revati has already explained, and progesterone receptors A and B are downregulated. More so, the progesterone beta isoforms are downregulated more than alpha, and then A form, that is A isoform, that will ultimately result in progesterone resistance. Overexpression of estrogen receptor alpha reduces the beta V3 integrin and alters the uterine receptivity. So the effect of adenomyosis on reproduction is impaired gamete transport infertility, that will lead to infertility, poor implantation, poor placentation, leading to miscarriages and all the complications. So having looked upon so many causes for subfertility in adenomyosis, now we have to think about something, what we can reverse, how we can reverse this and improve the fertility. But we do not have like standard consensus for this. Only few case reports and controlled small series are there. So treatment of subfertility in adenomyosis, it mainly three components. One is medical management and conservative surgical management, and third is assisted reproductive technology. So the management options for adenomyosis, the medical management options are GnRH, Gnrh, Aromatase. These three are playing a major role. Then the other medical management like OCPs, Dinosol, intrauterine, LNG, IUS, all those things can be temporarily, they can suppress the symptoms. Uterine artery embolization, HIFU, they are all other sorts of medical management, conservative surgical management. So now let us see what happens to the role of GnRH analogs. These GnRH analogs are very, very effective in reducing the size of the lesion, and they facilitate the fertility. After 3 to 6 months of GnRH, the mean uterine volume is significantly reduced from 180 cc to 86 plus or minus 67 cc. Post-operative GnRH for about a period of 24 weeks after adenomyomectomy also improves the pregnancy rate. The risk of rupture is less than surgical management. Pre-operative GnRH usage reduces the surgical difficulties and blood loss also. So this was taken from Zua et al. I think Dr. Padmashri also has taken the same references. Then GnRH analogs for there are so many studies that administration of GnRH analogs prior to IVF significantly increases the chances of pregnancy in infertile women with adenomyosis. Long-term GnRH preterm before FET significantly improves the IVF outcomes in patients with adenomyosis. So the main concept is try to reduce the volume of the adenomyoma or volume of the uterus, then go for FET. Since adenomyosis is seen in late 30s and early 40s, these patients are ideally suited for ART. So then how do you proceed with ART? So pre-IVF GnRH for 3 to 6 cycles optimizes the ART outcome. So what the GnRH analogs do? The GnRH analogs reduces the expression of aromatase cytochrome P450 in eutamic endometrium of the women with adenomyosis and endometriosis. So when this particular enzyme is suppressed, the local production of estrogen level, E2 level, is also reduced. So again, uterine natural cell activity is also modulated. It can also suppress the generation of peroxynitrate, a compound that is known to cause tissue injury, where we say that tissue injury is the most important cause for origin of adenomyosis. So what happens to the other drug, that is Dynegest? Dynegest has undergone a randomized double-blind multicenter placebo-controlled phase 3 trial in patients with adenomyosis at Japan. The drug was very effective, well treated, tolerated, and used in the treatment of painful symptoms associated with adenomyosis, not complicated with severe uterine enlargement or severe anemia. So that means Dynegest can only control the pain, reduce the bleeding, but it does not alter the size of the adenomyoma drastically. So it can be only used for a control of this bleeding and then correct the anemia. So there was again another study where you can compare Dynegest versus CEOCs in the women with adenomyosis. Here they are again not useful for fertility treatment, only for pain management. We can use COCs with Dynegest, and among the two, Dynegest is found to be more effective. But the reduction in the volume, uterine volume, is not as much as that of GnRH analog. Then comes the wonder drug, the second line agent, that is aromatase inhibitor, because we know there is overexpression of this aromatase in adenomyosis. So by suppressing the aromatase, by using aromatase inhibitors like letrozole, along with GnRH, it can reduce the volume of the adenomyoma, improve the symptoms. So a combination of GnRH with aromatase inhibitors, the reduction in the volume is seen up to 60%. That has been observed after 8 to 12 weeks. So the most important thing is the combined use also reduces the thickness of the junctional zone. So that is very important. When the junctional zone thickness is not corrected, there is going to be repeated implantation failure. Again, rupture of uterus following pregnancy is not there when medical management is used. So there was a newer theory by using antiplatelets like aspirin, it will retire. Tissue injury and repair is being very well, it can suppress by antiplatelet therapy. Platelets induce epithelial mesenchymal transition. Fibroblasts will be converted into myofibroblasts. Antiplatelet treatment suppresses the myometrial infiltration. It reduces the myohyperplasia and hyperalgesia, reduces uterine hyperactivity, and systemic corticosteroid levels also reduce. It reduces the volume of the uterus. This is according to the 2016 article by Bosuo et al. So then now our next question is, having given all these medical management prior to ART, prior to infertility management, are you going to go for surgical management, correction, or ART straight away? So by surgery, it can be done either through laparotomy or laparoscopy or hysteroscopy or robot assisted. And the uterine sparing techniques for adenomyosis are, it can go for a complete excision of the adenomyoma if it is going to be focal, partial excision and cytoreductive surgery, non-excisional techniques like HIFU, etc. So you can go for complete excision. The mode of treatment is either a focal adenomyectomy or cystectomy. And non-surgical methods are uterine artery embolization, MRG HIFU, and the role of this treatment in infertile women, whether we can safely use uterine artery embolization or MRG HIFU is not very clear. So, but uterine artery embolization, which is very commonly done for fibroids, the same thing is being replicated here, but it can only avoid major surgery. But after the 2 years, the 44% of these women who have undergone UAE, they'll end up with hysterectomy. In terms of fertility, complications like ovarian failure, amenorrhea, and fistula formation can happen. Again, there is low pregnancy rate, high miscarriage rate, IUGR, preterm, and PPH. Uterine artery embolization is not suitable for patients with adenomyosis. Similarly, MRI-assisted HIFU ablation, there has been few successful treatment of adenomyosis with infertility that has been published. And this was an article which was seen in 2021 by same Zua et al., where he says the key message he gives is high intensity focus ultrasound is a non-invasive technique that has been used to treat focal or diffuse adenomyosis. Based on the small sample size, HIFU seems to be a promising treatment for patients with adenomyosis who wish to conceive. Further randomized control trials are required, and we need really a large number to determine the efficacy, safety, and fertility outcome. So coming to the conservative surgical management, whom should you subject to conservative surgical management? Abnormal uterine bleeding if the patient has got not responding medication, severe dysmenorrhea, recurrent abortion, and recurrent implantation failure, these women can be subjected for uterine sparing surgeries. So the need for uterine sparing surgery is also increasing because many women, they get married late and they wish to preserve the fertility. Symptomatic women with strong desire to retain the uterus. So all these becomes indications for uterine sparing surgery. Whether to go for laparotomy or laparoscopy, it depends upon the expertise of the surgeon. Robotic adenomyomectomy or hysteroscopic adenomyomectomy could also be done. Laparotomy has got an advantage that we are able to palpate and recognize the margins, and approximation could be good. Then surgery for focal adenomyosis, it could be either a classical technique that has been followed, Time-Volt from Hayams, Grimbisis, Wang, and others. And the triple flap technique of Osada is gaining more popularity in Japanese countries. So this is the triple flap technique where the entire uterus is open and including the endometrial cavity, and then you remove the segment of the tissue that is found between the outer perimetrium and that of the endometrium. So this once when these tissues are excised, then by 3-flap technique, this closure can be done. So this can be either done by laparotomy or laparoscopy, and partial excision, or whenever you find a focal area of adenomyosis, that area can be removed and reconstruction can be done. So this is mostly the posterior uterine wall is a common site for adenomyosis, and it can be repaired either through laparotomy or by laparoscopy. So again, in focal adenomyosis, by removing this mass, focal adenomyotic lesion, and then you can make a flap so that there will not be much of risk of rupture during subsequent pregnancy. So this was a study by Grimbisis published in Fertility Sterility Journal, where he has compared complete excision, partial excision, removal of the cystic adenoma, and non-excisional technique, that is HIFU, and the uterine artery embolization. There he found out that removal of cystic adenoma gives a better, highest pregnancy rate of almost 100% when compared to partial excision and complete excision. So still they are not as bad. Complete excision is not as bad, and it is comparable to that of the local cystic excision. So now coming to if you are subjecting these women for ART, what are the protocols to be followed? Both ultra-long and agonistic protocols are equally effective. GnRH pre-treatment helps to induce deserialization of the adenomyotic deposits, rendering the disease inactive, and the volume of the uterus is also reduced. Theoretically, before IVF, it has got a beneficial effect on implantation. FET following ANTAC protocol has the highest number of retrieved oocytes and the lower dose of gonadotropin and tend to increase the pregnancy rate. However, insufficient evidence is available to support the preference of any particular regime over another. See, both the regimes are found to be equal, but the ANTAC protocol gives the highest number of oocytes that are retrieved and the lowest dose of gonadotropin. Whereas when you are going to use a long-term GnRH analog prior to ART cycles, maybe you will need a higher dose of gonadotropins. Still, good number of oocytes can be retrieved, and it also gives ideal results. GnRH antagonist protocol appears to be inferior to GnRH agonist long-term protocol according to To et al. So GnRH agonist long-term protocol appear to be associated with increased pregnancy and decreased miscarriage rate. And again, GnRH agonist pretreatment should be more potently done prior to FET. In a low estrogenic state, when you go for an FET, it gives the best result rather than fresh embryo transfer cycles. So then the ideal way is to go for a two-stage in vitro fertilization. That is, first ovarian stimulation, oocyte retrieval, fertilization, freeze the embryos. Then you give prior to FET, give GnRH analog suppression for a period of 3 to 6 months with or without letrozole, so that it can cause the shrinkage of the adenomyotic uterus and the volume can come down to less than 100 cc, and then you do the FET in the first HRT cycle. This gives the best result. Again, mock embryo transfer is very much essential because it helps to assess the uterine cavity length and the position, because invariably in adenomyosis, the uterine cavity is quite long and it is also quite irregular. Choose the correct transfer catheter and alert the clinicians any extra precautions, like for the use of pinaculum or cervical dilatation. Mock embryo transfer is particularly desirable in those with enlarged or distorted uterine cavity. Single embryo transfer should be done because there is increased chance of preterm labor, preeclampsia, and second trimester miscarriage as compared to that of the control group in adenomyosis patients. Consequently, multiple pregnancies should be avoided, so single embryo transfer should be advised. Patient, especially who has already undergone adenomyomectomy, should be advised only SCT in the view to minimize the risk of scar rupture. So HRT protocol for frozen thawed embryo transfer is GnRH pretreatment is essential prior to FET. In a study where they have done by Neo and Chen 339 patients with adenomyosis, 194 received long-term GnRH plus HRT, that is downregulation plus HRT, and 145 women only with HRT. So they found out that the clinical pregnancy rate, implantation, ongoing pregnancy rates were much higher in downregulation plus HRT group compared to that of the HRT alone group. So then coming to uterine contractility, there have been so much talk about the hyperperistalsis and the uterine contractility in adenomyotic patients. Then if it is going to be so, then definitely we can say that the chances of implantation failure is going to be more and early miscarriage is going to be there. So can we use atazibone? See, if there is more than greater than 5 contractions per minute demonstrated in 30% of the patients undergoing embryo transfer, this will lead to significant adverse effect upon embryo implantation. This abnormal contractility is seen in adenomyosis that explains the higher incidence of reproductive failure. So routine use of atazibone does not improve the outcome according to some of the studies, but you can use atazibone in selected group of women. If you do then ultrasound screening, if you find that there are aberrant contractions, even that we have to do it in the mock cycle itself, aberrant contraction, then always we can try using this atazibone theory, or alternatively atazibone therapy. Alternatively, empirical atazibone therapy in women with adenomyosis and recurrent implantation failure could be considered. So the IVF results using either a lung protocol and other protocols are found to be the same. There is no significant difference in clinical pregnancy rate, miscarriage rate, and live birth rate. What happens to the outcome of IVF in adenomyosis patient? They definitely have a lower implantation rate, lower clinical pregnancy rate, and higher abortion rate. And it is not, one thing is, if implantation rate is not impaired in asymptomatic women who are diagnosed to have adenomyosis only at the transvaginal ultrasound. So this was a news to me. So women whom we diagnose adenomyosis by routine transvaginal ultrasonogram, who are asymptomatic, then the chances of IVF outcome is found to be good. Again, hoax attention, I have already explained. This was a Korean retrospective study where they have found out fresh embryo transfers versus FET following GnRH pre-treatment, where they found in their study, either if it is a focal adenomyosis or a diffuse adenomyosis, there was no significant alteration in the clinical pregnancy rate and miscarriage rate. But in general, the outcome is found to be good with pre-treatment with Gnrh Analog. So again, when we are doing fertility sparing treatment of adenomyosis in patients with infertility, there was a systematic current review. This was published in the year 2018, where they found out that spontaneous pregnancy rate after surgery is 18.2%. Surgery followed by GnRH, a higher spontaneous pregnancy rate was observed, that was 40.7% versus 15%. Also, when the procedure was followed by ART, pooled pregnancy rate was almost 38.8%. Use of GnRH seems to be beneficial with the results of surgery and ART, probably because of its effect on reducing the adenomyotic focus on the uterus. So again, asymptomatic adenomyosis patients did not adversely affect embryo implantation according to Banaglia. Comparison of fresh and frozen ET has got a higher crude pregnancy rate than fresh, that is 23.6% versus 15.5%. So impact of IVF is still controversial. Meta-analysis shows that there is 28% reduction in clinical pregnancy rate when compared to tubal and other factors. The difference is no longer statistically significant when selecting studies with women who underwent only one IVF or ICSI cycle. So we need to have pooled data. Then there was one important message, that is junctional zone thickness and implantation failure. This already Dr. Padmashri has highlighted. When the junctional zone is less than 10 millimeter, the pregnancy rate was almost 45% per transfer, while the rates were as low as 16% or 5% when they observed that the junctional zone was beyond 10 to 12 millimeter or greater than 12 millimeter. So MRI evaluation of junctional zone thickness is the best negative predictive factor for implantation failure. So when the junctional zone is thick, don't try to do the transfer, try to reduce it, reverse it by using Gnrh analogs and letrozole, thin out the junctional zone, then go for embryo transfer. Then adenomyosis and recurrent implantation failure. Women with recurrent implantation failure should be offered 3D or MRI to establish if there is adenomyosis. So important cause for RIF is adenomyosis, and sometimes the casual screening you may not pick up, but if you find that there is recurrent implantation failure, then you have to look into adenomyosis. Maybe in this stage, MRI can help us better than a 3D ultrasound, and we have to manage accordingly. Try pregnancy, that is when to try pregnancy after adenomyosis surgery. Try pregnancy after 3 to 6 months after everything is healed, and then you can suppress the patient with Gnrh analog. That will improve the ART results. And sometimes spontaneous conceptions do occur. Then what about the risk of uterine rupture? The risk is 1 to 8 women. That is why we are advising for a single embryo transfer, and elective LSCS should be done at an earlier stage. So post-operative pregnancy outcome that they have studied in Japan, where they have the highest number of surgical correction for adenomyosis, constituting around 90% of the global procedures done. So here they found out that 22% of these women, they became pregnant, and 80% of the patients who have conceived, they have delivered. So there was around 3.6% incidence of uterine rupture in the study. So this was an algorithm, routine infertility workup, find out if the woman has got adenomyosis associated infertility, try to reverse the adenomyosis with GnRH agonist or letrozole, and surgery is ideally not done unless the patient has got recurrent implantation failure, or when there is grossly enlarged adenomyotic uterus, then we can go in straight away for IVF and ICSI. Ideal is to follow the FET procedure. Prior to FET, we need to go for GnRH analogs. To conclude, adenomyosis is a challenging condition to treat the scenario of subfertility. It is interesting to note that ART, there were good pregnancy rate and good reproductive outcome in adenomyosis. Well-designed, adequately powered studies are required to find out the impact of adenomyosis on treatment of subfertility. So, with the proper use of manipulation by using GnRH analogs as well as letrozole, we can reduce the size of the adenomyosis as well as reduce the thickness of the junctional zone, and take proper protocols of IVF, proper mock transfer, single embryo transfer, and high luteal support is what is needed, because there is progesterone resistance here. All these things can reverse the adenomyosis and promote the fertility. Thank you, Rajapriya, for giving me this opportunity.
Thank you so much, madam. Ask madam one question.
Yeah.
Madam, what is your opinion about introducing Mirena for a short period of time to handle the junctional zone and then plan the embryo transfer? If in a very bad case, I'm saying, that the uterus is really in a very bad situation, very painful condition. Are there any papers or studies about it?
I think Rajashri has shown a slide where they have put in LNGIUS. LNGIUS definitely causes desudulization of the endometrium, thins out the junctional zone. So there is no harm in putting LNGIUS for a short term along with GnRH analogs.
So it's like a local and a central.
Local action plus the central action by the GnRH analogs and letrozole. Now, off late, I find the combination of GnRH analogs with letrozole gives the best treatment. Even for a patient who's not needing fertility, but needs only pain relief, it gives an excellent pain relief.
How long do you give letrozole?
How long?
How long will you give letrozole?
Maximum 6 months. Combined with norethistidone, because it's a drug which can cause severe reduction in the bone mineral density. So we have to be very careful. And although also the vasomotor symptoms will be very severe, that is why we have to supplement with norethistidone.
Because patient awaiting embryo transfer or fertility treatment, they are usually very skeptical about waiting for 6 months, ma'am. So usually we give
minimum of three cycles they should be given.
Okay.
She's talking about aspect. Yeah, anyway, we are having a full panel on pain management.
Yeah.
There are no more questions.
Somebody has asked for a letrozole dose and duration. Letrozole dose is, it depends upon the BMI of the patient, maybe 2.5 to 5 milligram per day, along with 5 milligram of norethistidine. Given daily.
Acyclical.
Yeah, so one question and madam has answered that, I guess, right?
Yeah, yes. So we can just move over to the panel.
Yes.
May I request you to introduce the moderators of the panel? And I think we really have a great session. Like it's been moving very smoothly from pathology to the imaging to the holistic management of adenomyosis. I think pre-treating is so important to optimize the fertility. Yeah, and Selva Priya, I must reintroduce you again as the secretary of South Tamil Nadu chapter, right?
Thanks.
So that's news to the world of IFS in Tamil Nadu that we have a new secretary for the South Tamil Nadu chapter. So I didn't mention that. You didn't mention it in the CV. So the next CV has to get updated.
Neither did I. Lineup is really good because see, the first thing is because of both the chapters, we've made it as module 1 and 2. And we are focusing entirely on adenomyosis this whole month. And even it's going to be a continuation of whatever we've spoken here in the next. So it's going to be a real feast for all of our IFS members. So without further delay, let's go into the pain management of adenomyosis panel. And for this, we are going to have Dr. Sudha Shivakumar and Indumati Joy as our moderators. Can we have the CV, please? So Dr. Sudha Shivakumar, she's Director of SS Fertility Center since 2014. And she's a diploma holder in advanced reproductive medicine and embryology. And her areas of interest is doing patient-friendly IVF, PCOS, and endometriosis in IVF. Welcome to moderate the panel, Dr. Sudha. And this is Dr. Indumati Joy. She's a senior consultant in IVF and gynec endoscopy in Nova IVF, Anna Nagar, Chennai. And she graduated from Keel Park Medical College, DGO from Stanley, DNB from Sundaram Medical Foundation, and fellowship in reproductive medicine in IRM, M, Chennai. And her area of interest would be minimal stimulation protocols in IVF, male for infertility, and gynec endoscopy. So we have very eminent moderators to take over the load of this panel. Over to you, Dr. Sudha Shivakumar and Indumati Joy for the pain management in adenomyosis panel.
Thank you very much. Thank you very much for the IFS South Tamil Nadu and the Chennai team as well. Now let me start the screen sharing and I will get into the question and answer session. Before that, I'll welcome all the panelists. Can I have the slides, please? Yeah, Dr. Deepa Tyagaraja-Murthy, my very good friend. She's a consultant and IVF specialist, visiting consultant at Motherhood, Cloud9, Kaveri, and Apollo Hospitals. She's MD DGO from Chennai, MRCOG from the UK, and she's working. She's having a fellowship in art and reproductive endocrinology from the University of Birmingham. Worked in the UK till 2007. Now she teaches DNB students in St. Isabel's Hospital. She's a fellow representative of IRC-RCOG South India and an executive committee member of ADENOMYOSIS. Welcome, Deepa, for a beautiful session now. And next is Dr. Pramya Nanjundan. She is MBBS from Stanley Medical College, MD from PGI Chandigarh, DNB and from DNB OG from JIPMER. She's having a fellowship in reproductive medicine in Women's Center, Coimbatore. I invite her to the panel of pain management in adenomyosis. Next is Dr. Sumati Premanand, a vibrant person. She's a managing director of Darshan Fertility and Women's Medical Center, Chennai. She is an executive member of the OXI, member Public Health Awareness Committee of FOXI, master trainer No to Violent Against Women by FOXI. Welcome, Sumati. Next is we have Dr. N. Siddhartha. He is an associate professor, Department of Reproductive Medicine and Surgery from Srihar, MBBS from Nellore, MS from Belgaum, MCH from Ramchandra Medical College, has presented 13 conferences and he has presented so many publications, as you can see on the slide. I welcome Dr. Siddhartha to this panel. Next, I welcome Dr. Amala Devi. She's a senior consultant OBGYN, Annai Perinbam Hospital, Dindigul. She has a lot of awards to her name. Without much ado, I would like to go ahead with the panel, please. It's going to be a friendly panel, so I have to ask Rajapriya's permission. I have shifted a little bit out of the thing because pain management, nothing to talk about for 4 cases. So I have shifted my interest, I have put my interest into it by adding infertility to it. So there will be totally 4 cases. I will be presenting 2 cases pertaining with adenomyosis and infertility. And Dr. Indumati will be talking about 2 cases which are not associated with fertility, but only the pain management. I hope you don't mind, Rajapriya.
Yeah, because actually the module is having a full panel on infertility. It's okay. You bring in more about the pain and infertility together as a problem.
Thank you very much. So let's proceed. I'll just give we have had an exhaustive lecture about adenomyosis by 3 eminent speakers before, so I will not be dealing with the basics again. So I will go on to the case presentation. So by now you would, I'm just getting the full mode. slideshow is not coming.
Can you guide her, please?
Okay, sorry. The first case presentation
Yeah, I think,
is, yeah, I got it. The first case is Mrs. X, age 25 years, and she is recently married for 18 months. She has regular but painful cycles since menarche. Now she is using ovulation induction by a local gynecologist. She has regular sexual intercourse, but they are painful. Her BMI is 25 and her hormones are normal. As you can see, nothing to comment about those. Semen analysis is normal. Her scan done now showed a bulky adenomyotic uterus measuring 9.5 centimeter into 4.2 centimeter into 3.5 centimeters. And it shows a thickened junctional zone. How much thick they have not mentioned. Both ovaries show small chocolate cyst of 1.5 centimeters each. And while doing it, probe tenderness was present. So what do we do next? What do you want to do to this patient next? How do we go about this? You can answer randomly, or should we go one by one? Do you want me to tell the names? Dr. Deepa, you can take the question. Dr. Deepa. Okay, if she's not available, who?
yeah, I can see
Deepa,
here.
ma'am,
Yeah.
you need to unmute. Yes, ma'am.
I'm here. Yeah, so this is a 25-year-old with 18 months of infertility with painful periods, is it? Painful
Yes.
cycles.
Dysmenorrhea,
And her scan has showed adenomyosis.
Yes.
So basically, when she comes again, I would do all the necessary tests. And because she's having adenomyosis and because she's very young, then probably, as we heard in the lecture, we need to know more about the adenomyosis.
Yes.
And because the junctional zone is thickened, we would be better off if the junctional zone reduces in thickness before we go on with any further treatment. So I would put her on Gnrh Analog for maybe 3 to 6 months, and then reduce the size of her uterus as well as reduce the thickness of the junctional zone, and then subsequently try ovulation induction, which might work with her.
Thank you, Dr. Deepa. I have wantedly didn't mention many findings in the ultrasound. I can show you the next slide. These are the things which we look for when we do a scan. So globally enlarged uterus, which was nicely covered by my previous speakers, but just to enumerate again, out of these 7 or 8 findings, we need to have at least 4 or 5 findings to find out or diagnose adenomyosis. So a more detailed scan with more information is needed. So would you want another mode of investigation like an MRI before you proceed with the patient, or this scan would do? Anybody can take, Dr. Siddharth?
Yeah. This patient, first of all,
better
rather than
MRI
going
can
for
be
an
also
MRI,
be taken. MRI is recommended in this case because she is infertile and she has got a chocolate cyst also. So how much thickness is there? MRI will give you a better idea before starting, as she wants to have the infertility treatment also.
Thank you, Dr. Amala. Anyone has any other?
yes. MRI is definitely, no doubt, is one of the beautiful modality of investigation to see junctional zone thickness and complete features of adenomyosis. But rather, I would be more worried in this patient. How is the tubal factor? Because next I have to treat the patient. Say, just telling the diagnosis of adenomyosis, the patient will be worried rather than being happy. But we should tell the treatment also next. So I should see how to evaluate the tubes in this patient.
Yeah. So
So
how do you want to evaluate?
Yeah, keeping the ovarian reserve is normal. See, first of all, how severe is the pain? See, pain, probe tenderness is all right, but are they able to have contact? Is the pain very severe enough that they are not able to have the regular sexual relationship? Then definitely this pain requires attention, because whatever we do, even IUI, whatever so matter, unless they have a natural relationship to an acceptable level, we cannot. So the pain is very severe, so as to they're not able to have a normal relationship, then my choice will be laparoscopy. Otherwise, my threshold for laparoscopy in this case should be very, very high, because we should not put the scope suddenly in a young patient, 25 years with 1.5 year married. But depends on how severe the pain is. Say, I will take a little elaborate history on the pain. See how frequently she's having the pain, whether the pain is, if she's a working lady, it's very severe, that she's not able to do her routine day-to-day activities or at workplace where she has to take more of leave. So I would like to elaborate more on pain in this patient before going for the next modality of investigation. Of course, a well-performed transvaginal ultrasound is okay for me to diagnose adenomyosis unless I am going to operate on her. Suppose I have a doubt whether it's a fibroid or adenomyosis and there's a focal lesion there. So if my skills have to be better on laparoscopy, or I have to be prepared for better dissection if that is going to be an adenomyoma. So though ultrasound, yeah. So that's the main thing is I don't deny MRI is good, but in this patient, my focus would be the next modality should be tubal factor. What is the better way to evaluate? My pain will decide. A patient's pain will decide. And if there is pain is not so significant related to my medications, then okay. Otherwise, I would go for a HSG.
Okay.
Okay.
As Dr. Siddharth said, actually, what you have described in the history is about the pain. Suppose if it is disturbing the quality of the life on an everyday basis with a severe abdominal pain continuously, where the patient is requiring the need for a medications for a pain relief or for sexual intercourse, then there will come a necessity to think about putting about the adenomyosis treatment first, followed by a fertility treatment. But if it is something like mild to moderate only at the time of like menstruation, she's having a dysmenorrhea or she's having a mild dyspareunia, I think we can go ahead with the fertility treatment after evaluating the tubal factor. By chance, while monitoring the endometrium during the ovulation induction cycles, if the endometrium is very thin because of your thickened junctional zone thickness, and if it is going to interfere with the further processing, then we can think about treating the adenomyosis and taking a call forward.
So for the for this case, let us assume that she has mild pain because she's been on ovulation induction and she's been trying for pregnancy. So we must assume that the pain factor is not that much. And for our discussion's sake, so let us keep that part of it separately for Dr. Indumati to discuss, and we will go ahead with the fertility treatment part of it, so that it makes a discussion in that particular direction. So, okay, now we assume, so as you both have easily told me that there are two types of treatment. One is for pain management and the other one is for fertility. So now, if at all you're going to do pain management for this patient who has only mild pain, let us assume she has only mild pain. It is not disturbing her regular activities and it is not disturbing her sexual activities. So what sort of pain relief or a disease relief you would offer to these patients before you start on the fertility treatment?
Okay, as far as pain is concerned, before I assess the pain, I would definitely make a detailed history of when do symptoms occur typically, how severe is the symptom for her in the scale of 10, is she already on OC pills or any other contraception or any other things, or if it is only related to menstrual cycles, or is she troubled throughout? Is it always associated with dyspareunia? Is there anything which is improving her symptom? Is there anything which is worsening her symptom? Because this is going to be a long-term patient with us, not only for fertility, but for her adenomyosis too. So it is our requirement to not just look at the fertility part or the pain part, but also look at this patient in a holistic manner, because she's going to stay with us for very many.
She's here for only ovulation. She's already done ovulation induction. She is not ready for the pain, because if she's come for the pain, she would tell that as a primary problem. Now she's come for a fertility treatment. So if we, like for example, if a patient comes to me for fertility and I go on talking to her about the pain, then she may be thinking that I am looking at something which she is not very much worried about.
In this patient, my choice would be IUI. The reason is I would not wait for a natural conception in this case, because when I see endometriosis there, the time to pregnancy should be as quick as possible.
We have seen only adenomyosis, an enlarged uterus.
No, there is 1.5 centimeters endometriotic cyst.
on both.
So whenever I see endometriosis, always I'll counsel the patient the time to pregnancy should be shorter. IVF, I don't think in this patient, one thing is short duration of marriage. In young patient, AMH of 3, I would not be in a hurry to go through, take her through IVF. So if at all I have a chance to treat this patient, IUI would be a better one, with ovulation induction preferably.
Any other comments before I go to the next step?
We're asking about pain.
All right. So will you give pre-treatment with oral contraceptive pills?
Yeah, in case if I think of IVF, that's a different thing. But IUI, usually, I don't think that will help.
All right. What about Gnrh agonist at this point?
No, in endometriosis for fertility aspect, there is no benefit of giving a pre-treatment suppression. But if the patient has got a pain and you want to try giving her some pain relief before, and she is not sure about the treatment immediately, fertility treatment, then in such case, because this session is on pain, so maybe in such case, if you're thinking probably Gnrh agonists can give a short-term relief, and that too, they are not the permanent solution because the symptoms rebound back. So apart from that, you have to give some you can think about Dienogest, or you can think about some Ulipristal or something, because whenever you give agonist, they come back. And this pain relief measure should only be thought when the patient is not so keen on fertility.
So her main thing is fertility now, isn't it? She wants a baby.
No, then
so she wants a baby. She's had 18 months of trying.
Yeah.
So
then,
definitely she would benefit from Gnrh agonist.
Yeah. Not actually in this patient, if we are planning for an ART, that is like an IVF, Gnrh agonist will play a vicious role.
No, not for IVF. She has just come to your clinic. That's
just for fertility.
Yeah.
In that case, as a Gnrh agonist, instead we can put them on a continuous cyclical OCPs or progesterones, because even if you're going to give a Gnrh agonist for 2-3 months, it is suppressed well. Then subsequently, you have to wait for a little longer period for your return of cycle and start for an IUI or an ovulation induction procedure. In that case, progesterones will be doing a better job as compared to Gnrh agonist.
I have not put that slide, but then it is found out that giving progesterone at this point doesn't help the patient's pregnancy rate or the pain relief at this point of time. Progesterones, when compared to the other modalities like Gnrh analogs and Dienogest, progesterone scores much lesser. So we'll have to keep that in mind while we starting progesterone. What about Dienogest?
Yeah, Dienogest will be a good option for her. It will also take care of her pain.
As well as a comment about that. I don't know whether I have it here. When you give Dienogest, it takes a longer time for them to recover from the anti-estrogenic effect. So while we are thinking about her becoming pregnant quickly, so probably Dienogest would be the second line of choice when compared to Gnrh analogs, where we get back the patient as quickly before you start the treatment. Otherwise, Dienogest and Gnrh analogs scores the same.
The Gnrh analogs you are giving for pain relief, madam, here, or?
Pain relief and to control, at least to reduce the size of the uterus a little bit before we proceed on to the next set of treatment.
Okay.
So what we did was we gave her 2 cycles of ovulation induction with letrozole, and we asked them to try naturally because she was not ready for any other treatment. And during this 2 cycle, everything was normal. Follicle growth was normal. Rupture was normal. Obviously, there was no pregnancy. Then she was not ready for HSG, or because she is already in pain, and she was not willing for a laparoscopy at this point of time. So the next cycle, she agreed to do an IUI because it may give her a 5 to 10% an extra pregnancy chance. So she went ahead with it along with HMG. We did an IUI, and that also came back negative. So she was here with us 18 months of pregnancy. Now she's about 20-21 months of pregnancy. We tried a couple of treatment and still no pregnancy. And now what shall we do next?
She's actually married only for 18 months. Her ovarian reserve is normal and she's young. So since the basic things have got not turned out to be successful and she's in severe pain, we can give her some time actually and consider a treatment of either a LNG, that is Mirena, to put in place for a few months or a year, and then probably debulk the adenomyotic uterus and then take it out and consider. Or else, I think we can also opt for a treatment of MR-guided focused ultrasound if patient is affordable and understanding the pros and cons of MRG like this.
So you said leave her for a couple of months. What would you
see? One is I would, even though the return of, as you said, the Dienogest takes a longer time because of its anti-estrogenic effects. Yeah, even if the patient is fine and comfortable with taking the drug and complaint, we can put them on a Dienogest for a period of even 6 months. Or else we can put a Mirena intrauterine and keep it for almost 6 months to 1 year. And probably after that, we can consider going ahead for a fertility treatment because she's young and she's married for only less number of months. And here it will play a role because she has tried the basic treatment. It has turned out to be negative. And there is no hurry for an IVF. On the other angle, if she considers both as equal importance, like pain also to be relieved significantly, fertility also she does not want to postpone, then we have to take the treatment in a different direction of considering an IVF, putting them on analogs and that way. But if she's not, if she's agreeing with the weight, I think we can put them on a year of like a Mirena or else on a Dianogist, whichever she agrees to, or else we can consider even a MR guided focused ultrasonic therapy if she understands it.
Yes, whatever.
One more thing.
Yeah.
Yeah. There's also another option of treating her with, see, what we used to do before is, even for an IUI cycle, give them, like how we do it for an IVF, give them ovarian stimulation injections along with GnRH agonist. That is also possible. You can give them a small dose of GnRH agonist every day along with your HMG. That is possible for such a case with adenomyosis for your IUI itself.
Just like long protocol.
Just like, yeah.
Ma'am, Dr. Amala, ma'am, what will you do, ma'am?
No, already 2 cycles of ovulation induction has shown good follicle and rupture. You can convince the patient, counsel her to go for 2 more months. And then you can try IUA also again, not go for much of drugs.
Okay.
You can try IUA again.
Yes, madam.
At least for 1 or 2 more times, counsel her and then convince her that because already she has got the letrozole and she has got good follicular growth and rupture was normal, no? So you can wait for some more months. Don't put her on more of drugs. And
the MR guided focused ultrasound, whether it will help in diffuse adenomyosis, it may not help that much, maybe.
It doesn't. Yeah.
Yeah, because and one more thing is
Siddharth, we have few more slides coming up. Please hold on. Okay.
no, because it's, like Dr. Pramya was saying, it is a good modality, but not probably when the adenomyosis is diffuse.
Yeah, we'll discuss.
May not be that great.
Move on, Siddharth.
Okay, so we did the laparoscopy for this patient to while away the time and to prove to her that there is the need for her to wait for some more time before we go to the IVF. So in the laparoscopy, we got a uterus was uniformly enlarged, diffuse adenomyosis. A small endometriotic cyst was seen in both ovaries. Cystectomy was done. Tubes are both patent, and there was absolutely no additions. So after this point, we have to decide whether to straight away go for treatment or to give her any Gnrh analogs and wait for a couple of months. Please, your inputs.
The immediate treatment is the only way to probably go about, because she has patent tubes and we have operated her on endometriosis. So we should not delay the treatment in case of any endometriosis once you operate. And if you did some adenomyometry or something, probably we have to wait. In this case, probably there's nothing to wait, and surgery would bring some kind of pain relief to, no matter how far extent it could be. Then we can start the treatment because everything is good in this patient.
Any other
focus? It is better that we continue the treatment for fertility straight away at this point of time instead of a break.
No, there should not be a break. That's what evidence and many people believe.
Yeah, no break.
Yeah. We did differently. So we gave one dose of Gnrh analog just to satisfy ourselves, because one dose of Gnrh analog doesn't do anything. But to satisfy ourselves, we gave 1 dose of Gnrh analog, Lupride 3.75 mg was given. Following the next cycle itself, there was no break. Then following the next cycle itself, we gave 2 cycles she had of again ovulation induction, as Madam said, 2 cycles of ovulation induction with HMG and IUI. But then no pregnancy was there. So now what do we do?
So she has completed.
Go for IVF.
Sorry, Dr. Sumati, I didn't hear you.
Completed 4 cycles of IUI now.
Yes, 4 cycles of IUI, 2 before laparoscopy and 2 after laparoscopy. No, 3 cycles of IUI, 3.
And any AMH was repeated post-operatively? Any AMH was repeated, or anything AF count change was observed? Anything is observed post-operatively? Because
so with the 2 cycles of ovulation induction, she responded quite well. AMH was not repeated again, but there was no problem with the follicle count.
See, now I would like to know about the uterine volume. Before, we've completed 4 cycles of IUI, and obviously we'll be thinking about IVF. We might not have mentioned it to her. Check the uterine volume and recheck the junctional zone once again with a good transvaginal ultrasound scan.
What was the volume, Sudha?
The volume was not mentioned. That's what I said. That is the reason I said the scan was very what to say. It had only very minimal findings. This was just the finding of the scan.
Okay. Yeah.
We could calculate the volume. We could calculate it ourselves roughly. It will be around 16 to 18.
No.
So, at which point you people will suggest an IVF to her? Is it a good time to suggest IVF to her?
Yeah, once we are doing at least 4 cycles of IUI histolaparoscopy, but already there's nothing much we did in histolaparoscopy to keeping except cystectomy, but 2 more cycles we can try because evidence clearly says that till 4 cycles of IUI, the cumulative pregnancy will keep on improving, and after that it will fall generally. But though this, again with a word of caution, this evidence is for unexplained infertility. So we can't keep it interpret for every case. But generally, that is what is the nearest evidence which is available. So I would like to try 2 more cycles with gonadotropins along with oral ovulations in IUI. Or we can just try gonadotropins alone instead of avoiding oral ovulations, thinking that there could be some effect on the endometrium by the oral ovulation. So these are the things.
Any other suggestions?
Because she's very young, my temptation to go to IVF is less. So probably put her on letrozole for a few months and try and shrink the adenomyosis a little more. If not GnRH agonist, at least give her letrozole. And then maybe subsequent months think about further treatment.
Okay. So if at all you decide to go ahead with IVF, would you give any pre-treatment before the IVF?
The reserve is very good. I think we can give 1 or 2 to 3 doses of analog and then do an ultra-long protocol instead of a routine. So probably that might help for an improved implantation also subsequently if you're planning for a transfer.
All right. So you have given, let us assume you have given 2 cycles of Gnrh analogs and the patient doesn't get a period after Gnrh analogs. How do we proceed at that point?
No problem. In Gnrh analog, we don't expect a period actually.
Don't wait for a period.
So we just like first dose is given if you're going to give a Lupred. After 4 weeks, second dose, and after 4 weeks, you can directly check the hormonal values for suppressions and start the stimulations.
Okay.
28 to 30 days after the dose, you can start the treatment.
So as you correctly said, we will not give Gnrh analog before IVF because it shows there is a decrease in the reserve. So it is better to go ahead and stimulate it, and then you do a frozen embryo transfer after the downregulation. What about letrozole? As Dr. Deepa said, you could try letrozole before we start an IVF, but ideally we do the IVF first and then do the letrozole or Gnrh analog and proceed with the frozen embryo transfer. So if you're going to use stimulation, what type of ovulation induction protocol you would prefer?
It's a down. If you're putting in an agonist, it will be a down-regulated protocol to start with recombinant FSH.
So is it going to be an antagonist protocol or an agonist protocol?
It's an agonist protocol.
Agonist protocol.
Yeah, alternatively, even antagonist with freeze-all and followed by suppression can also be tried because there's some argument disfavoring agonist protocol saying that the suppression will be so much to requiring little more doses. But I don't believe much into that. But because we have been using agonist protocol for a long time before all this antagonist has come, and we were all happy. So nothing like that. But nowadays, the recent trend says so there are one group of people are with the opinion that do an antagonist protocol, freeze all, and then go for a suppression and frozen embryo transfer.
No, now our patient is already suppressed. She has got 2 doses of Gnrh analogs and she has not got periods. So
she has to go with the agonist protocol. There's nothing like there's no point in waiting for the periods again.
So you'll give agonist again and start, or you start straight away?
You can start. Actually, there are 3 doses. The ultra long says up to 3 doses, but don't have to be that much. You can start the stimulation.
Yeah, so long protocol, there is no doubt about that. So once we do the long protocol, would you prefer a fresh embryo transfer or a frozen embryo transfer for these kind of patients?
Frozen embryo transfer, definitely.
You're already on an agonist protocol. So what is the purpose of going ahead with the frozen embryo transfer? You're already suppressed. We have already suppressed the adenomyosis to a certain extent. So why do you need a frozen embryo transfer on these patients?
Only for one reason, that if the stimulation is going to be aggressive for this kind of patient, the progesterone is going to be high. So because as you all practice in a situation of cumulative pregnancies, not for that pregnancy for that cycle, so we tend to get more number of oocytes. Our dose will be a little higher compared to what the Westerners say. But in that context, if you are speaking about maybe the progesterone is going to be high, and high progesterone and long protocol is not so much important. I can understand that, but still, that when there is an option otherwise to do better in such patients. Otherwise, there's no specific indication to go for a frozen embryo transfer. Everything else is okay.
Here, anyway, she is suppressed with 2 doses of analog, and we have planned already to go ahead for a stimulation. Yes. So if the final response is like an average kind of response, less than 15 oocytes, and if your progesterone levels on the final day of trigger is normal, I think you can consider for a.
But now the fashion is this 2-stage
the situation is high, or if she's like high responder, after the retrieval, you can put her on 1 more dose of analog and carry forward, and after 4 weeks, prepare her for a frozen embryo transfer. There is no need to induce a withdrawal bleed in her.
Okay, so how many doses, number of embryos during a transfer? Would you have a single embryo transfer, or you have a multiple embryo transfer?
It depends upon the the quality and the grading of the embryos and what day of embryos you are considering transfer. It's a day 3 or a blastocyst. I think in any way, adenomyosis per se has got a lesser implantation as compared to the classical scenario. So I would say would prefer it to grade A or grade B blastocysts.
Any other comments?
She's young, and if her quality of embryo is very good, I would go with a single embryo transfer.
Yes, not only that, there is increased risk of.
If I can interrupt you, just try to wind up the infertility part of it, because our focus is on pain management. We are close to 5:30, 5:40 almost. Okay.
All right. So sorry to go on like this. Then the last question is whether you will transfer a HRT cycle for FET cycle or a natural cycle for FET cycle. So somebody answered, I think you will go for down regulation and HRT cycle.
Yeah. What about go for a natural cycle?
What about the ERA in adenomyosis patients? It's found out that the implantation window is a little altered during this adenomyotic patients. So ERA, endometrial receptivity assay test may be an important test which can help us to find out the implantation window and change the date of embryo transfer.
Only if she's had multiple cycles of treatment.
Yes. So now straight away we'll go to the second case. This is a 39-year-old lady with a 10 years primary infertility. Her menstrual cycles are regular but painful. Her FSH is in borderline 12, LH is 10, and AMH is only 1. She's had many cycles of ovulation induction and IUI earlier. Her husband's 7 parameters are normal. Now, the scan is, this is an old scan, ultrasound, the uterus enlarged to 10 centimeters, posterior wall adenomyosis, thickened junctional zone for 10 mm, and both ovaries are normal with AFC count of 3 and 3. This is an old ultrasound. Her previous, she has had two IVFs before. The first IVF, she has had 6 eggs in an antagonist protocol, and 3 blasts were frozen at that time. And after which she had 2 doses of Gnrh analogs, and FET was done with 2 blasts during the first time. And she took a 2 months break after that, and she went ahead with a laparoscopic adenomyomectomy, followed by 1 dose of Gnrh analogs, and the second dose, FET was done. Again, 1 blast was transferred, and the result was negative. Now she has come to us, and the scan is like this. Ultrasound, uterus is enlarged to 12 centimeters, posterior wall adenomyosis measuring 5 centimeters, thickened junctional zone of 10 mm, bilateral hydrosalpinx, endometrium is 4 centimeter. So would you do an IVF straight away, or you would do a repeat laparoscopy to address the bilateral hydrosalpinx?
Laparoscopy.
So directly you can go for IVF. Hydrosalpinx, how can you treat that? Already she is 39.
Madam, you are muted, madam. Yeah.
So no place for surgery, straight away go for IVF?
No. Laparoscopy?
IVF.
At this point of time, the hydrosalpinx needs to be addressed. You need to see what else is happening. We can't do anything more. We have to be meticulous in what we are doing. I would prefer to do a laparoscopy on this patient.
And for Dr. Sumiti, what is the purpose of the laparoscopy?
I will remove the hydrosalpinx with the consent. If at all,
Only for the hydrosalpinx part of it.
Hydrosalpinx, we are not going to benefit more with the laparoscopy now. Hydrosalpinx, what are you going to do with the hydrosalpinx?
it reduces the rate, no, madam.
The first question is whether we are going to transfer in her, or are we looking at the surrogate? Because it's a case of recurrent implantation, where practically we do that. Because here we may be hesitating to say, but practically it's all whatever the surrogacy law says, but that is the situation now. But otherwise, these patients are not a patient to be again transferred with 5 centimeters adenomyosis. I think
already had
we're not just, with the 5 already operated, and again she's got a 5 centimeter thick posterior wall. This is not a patient which is going to work. And whether to treat hydrosalpinx or not for stimulation, the answer is no. There's no need to treat hydrosalpinx for stimulation. But we need to counsel and see the other options. Transferring in the same uterus may not be able. I mean, it's not going to work. And whether surrogacy is practical in this era, with all the difficulties and law being very, people are very scrutinizing nowadays. The law being very strong.
Hydrosalpinx can be aspirated also if you to adjust.
That's right. Yeah, that is not a problem exactly. The age is a problem. The AMH is a problem.
So
and
what about high intensity?
Adenomyosis is the biggest problem.
Yeah, there is another newer thing called HIFU, where you focus only on the adenomyosis, the laser, and then you reduce the adenomyotic size. Will that be an option for this patient?
Yeah, definitely. Yeah, these are the cases where probably these things can be tried, and the experiences of these are, if the experience is positive or whatever it is, maybe that will create a lot of awareness and opening up there.
Doesn't it say that you need to be less than 38 for a HIFU? Is it 38 years of age for HIFU?
I have not had any personal
Already she has got
information.
hydrosalpinx, and then already she has been tried, for so many times. So better
go for IVF, madam. Yes.
The age is a factor here. 38 years. If she's not having any complications, then it's okay. But with all these complications, adenomyosis and then hydrosalpinx, then better go for further management, no?
So would you suggest donor gametes for this patient if this doesn't work?
Anyway, her hydrosalpinx has to get treated.
If you're going to transfer
one is
into
that.
her,
Second thing is, like, she has undergone 2 day 5 transfers, and anyway she's elderly enough also. So probably before considering the bigger option where there are too many issues with the laws, I think you can consider the donor gametes.
Will that improve her success rate given the adenomyosis and
see, we are not very clear with the embryo part. Like, see, even sometimes if like even the gametes are like very good, sometimes the change of gametes improves your implantation rates.
Yeah, that's the only reason I brought this slide up.
Yeah, sometimes because you can't, like, for the present situations, it's not so easy to do a surrogate. So in such a case, I would say, like, yeah, you consider a donor gametes in place, because anyway she's beyond 35 and she has gone, like, I think for the first cycle she had 2 day 5 transfers. For the second, I think she had only 1.
Yes.
So that means, like, you don't, for a cycle she produces only limited number, and you don't know about the aneuploidy status of the embryos considering her age. I think we can consider a donor gametes before considering for the next level.
Right. I guess thank you all the panelists for indulging me in infertility and adenomyosis. Thank you for all your inputs, and I will hand over the stage to Dr. Indumati.
Thank you, Sudha. You can stop sharing the slides. Can you see the slides?
Not yet.
No. Yes.
Can you see?
No, ma'am.
Not
Not yet,
yet.
ma'am.
Slide share, please. Yeah, it's open.
While she's trying to share her slides, if I may ask the panelists, how many of you have been forced to do a hysterectomy for an adenomyosis patient as they wait for fertility to happen and multiple attempts fails? At what threshold do you think we should talk about hysterectomy for pain management?
Really, when all your methodology fails, whatever has been described, like progesterones, danosols, LMG, analogs, and even in adenomyometry, sometimes the patient's quality of life gets disturbed so bad and so pathetic. I have seen like 2-3 clients. Personally speaking, I have not been put forward into a situation where I have to do a hysterectomy, but I have seen clients like coming back after hysterectomy for the next phase, like a surrogacy or an adoption, because their thing is like they feel so much better that after this hysterectomy, their life and their quality of life has changed significantly and their stress part has come down very low and they lead a very good quality of life. So if the adenomyosis is so bad and not responding to any kind of medical or a surgical fertility preserving management, sometimes, yeah, at times you are forced to do a hysterectomy.
I guess Indumati is back on track.
Personally, I have not done any hysterectomy for adenomyosis. Mirena has changed the scene quite a lot, actually. People do benefit from Mirena. Giving them Mirena for a year and then going on with fertility treatment has changed the field in a great way.
Sometimes, madam, even if we put them on a Mirena, I mean, I'm saying like a very bad adenomyosis, when you put them even on a Mirena, sometimes they're spotting, they're pain almost like every 20 days or 25 days once, they have to be dependent on some injectable painkillers. So in such cases, even when we are adding oral progesterones along with it, sometimes the quality of, I mean, the need for a painkiller like stays all the while throughout a month, probably once or twice. In such cases, rarely, I would say, like not hysterectomy, but we'll still keep postponing some way or the other, changing the drugs. But sometimes, very rarely, I would say Mirena also does not work so greatly. But majority of the time, Mirena saves you.
Indumati, you can start off, Pam.
Yeah, you can see my slides, Dr. Priya?
Yes.
Okay, so this particular patient, she's a 31-year-old unmarried lady with regular cycles, 3/30 with excessive bleeding for the first 2 days, with dysmenorrhea relieved once the periods resume. And she's been having this problem for the past 3 years. So she went to the family physician who reassured her and gave some antispasmodics and some vitamins. Problem continued every month as she was contemplating marriage. She decided to meet a gynecologist and have a checkup.
Can't hear you.
Yeah, the slides are not moving.
Ma'am, please click inside the slide and you can move, ma'am.
Yeah.
Yes, ma'am.
And besides the hormonal test, an ultrasound of the pelvis and the abdomen was done. So it showed a bulky uterus with diffuse adenomyosis, endometrium of 6.8 mm and homogeneous. She also had a associated problem, endometriotic cyst of 3.5 into 4.4 centimeters. Left ovary was normal. Other abdominal scan was also normal. So how will you counsel this patient to Dr. Pramya or Dr. Siddharth? She's worried about her fertility status and the pelvic pain as she's getting married. She wants to know how she can control the pain because she thinks that the pain is the reason that she may not conceive at all in future. So Siddharth, can you start?
I think actually when she's
She's actually come for a premarital counseling. Yes.
Yeah. Which I don't do, but anyway,
okay.
for the discussion's sake, probably I would first start with the
she
OC
can
pills
be
and
put on OC pills, combined pills. She can put on combined OC pills cyclically to reduce 50% of the blood loss, as well as the pain also will subside. So initially, you have to convince her with OC pills, because the NSAIDs will give only temporary relief for her. But as she is going to get married, better always to keep her cycle also regular, as well as the pain also will be reduced.
Yeah, this is a young girl.
But I think she had some endometriatic cyst also there in her this scan finding,
yes,
USC finding.
would you like to interfere with that before marriage, or what would you? What will be your advice?
No, not now. Better don't do any surgery before marriage. You can give some. She can be treated conservatively. Conservative management can be given.
Yeah. This is a patient who requires a good amount of counseling for two things. One thing is pain. The other is the future fertility. For the pain part of it, I would like to offer her an NSAID and oral contraceptive pill, probably containing desogestrel ones. You have to be specific in choosing the oral contraceptive pills for ladies. The ones contain desogestrel actually have a better pain relief. She can actually take it cyclically or even continuously for about 2 to 3 months to skip the pain part of it. And as far as NSAID is concerned, people very often develop gastritis following these medications. I prefer to use a rectal route for 1 or 2 days during the pain so that they can get rid of it. This will be the initial offer from me to the patient.
Yeah, would anybody suggest Dynogist for her?
Dynogist can also be.
Yeah, if she is having a lot of side effects with oral contraceptive pill, and if she's not able to tolerate it, then I would suggest Dynogist for her until she decides to have a baby.
Yeah, so when would you like to see her once the marriage is done, or what do you want to do? Will you keep her at the follow-up?
Yeah, generally we have to keep her under follow-up if you are putting her on OCPs or Dynogist, whatever, at least once in 6 months for the first year and subsequently probably yearly once.
Yeah, so if you want to complete the premarital counseling for fertility also, if you see an endometriosis, better to go on 31 year, keeping an Indian ethnic background, better to go for an AMH also, because abdominal ultrasound may not be so much to see the AFCs, handle follicular count. Better to go for an AMH to complete it.
Yeah, I have actually told her to come back after the marriage, and again, based upon the 7 analysis report and a complete workup only, will be working for fertility. So as of now, we've just put her on pills and then pain relief with some antispasmodics. That's what she's continuing. So we'll go to the next case. This is a normal patient whom we say day in and day out. She's a 42-year-old para to live to, last childbirth 12 years back. She's also sterilized, had menorrhagia and chronic pelvic pain for 2 years, which was managed by a gynae by oral contraceptives. And cyclically, she's been taking it for 2 years. Ultrasound was done 1 year back, which showed an anterior focal adenomyosis measuring 3.5 into 3 centimeters with 2 to 3 seedling fibroids as well. Both ovaries appeared normal. She was given an injection Lupride depot, 11.25 milligram, 6 months ago. And patient resumed her symptoms since last month. How would you proceed from here? Madam, Dr. Amala Devi?
No, she can have LNG releasing IUCD can be given for her as she is already 42 now in the 4th decade of her life. So that will be better, I think. That is a thing which can give you as a first treatment, line of management. But we will see whether how she is improving.
What will you give for her as a backup for the symptoms which she has, the pain and because she had a depot, she has the backache and then, the occasional flushes. She also has some additive symptoms along with this. So would you like to give anything else along with the Mirena?
She can be given this non-steroidal anti-inflammatory drugs can also be tried along with some antacids, and calcium can be given. Calcium can be as a substitute, she can be given. And because of her age also 40 years means nothing, not much has to be done except for this. We will try for some few months with Mirena and then we will review her, no?
Okay, ma'am. Dr. Pramya, would you like to give any add-back therapy for her or whatever madam is enough for?
Yeah, actually one is like, I agree with Marina because anyway she's 42 years old and prescribing OCPs is not a right choice for this age group when we have other choices. And thing is like, if you're saying like because of the hypoestrogenism, she's experiencing a significant amount of like hypoestrogenic symptoms. Yeah, probably putting a Mirena and adding a E+P orally, like estrogen plus progesterone can make, relieve her the symptoms of hypoestrogenism, and probably till the Mirena takes its effect, you can continue the oral progesterones for 3 months.
Some women are very skeptical about an intrauterine system. They may not like, they don't like this foreign body thing inside. So for such patients, what would you do?
Then in that case, I think Dynogest will be a good option for her for a period of 6 months to 1 year. Or else a simple norethistone if the patient is not affordable is also fair enough.
Depomedroxyprogesterone also helps in pain management in such cases of adenomyosis and endometriosis.
Depot is given once in every 3 months, isn't it? So
yes.
Yeah, once in 3 months because she's only 42. She's been having this pain for quite some time now. And how long will you take her on DMPA?
Actually, prescribing for a DMPA varies from women to women. Certain women are very comfortable with the DMPA. They choose it because they don't need to remember and they get a good pain relief. But at times, because of this bloating, intermittent spotting, and sometimes breast heaviness, people discontinue the long-term usage of Depot.
Actually, they don't come for follow-up. When we keep telling them you have to take DMPA every 3 months for a year, they usually ask for a permanent solution. So theoretically, we discuss that, we give Leupride and we give this and that, but then practically they don't turn up. So it takes, especially for the patients to get motivated for themselves. And if they are very much motivated to retain the uterus only, they are willing to take these medications. So if you have
all the patients are not responding the same. No, some
Yes.
patients they may be getting amenorrhea. Some patients are having intermittent spotting. Some patients are getting regular periods. So you should explain to them in clear that if the symptoms persist, that is, if you have got amenorrhea, you need not worry about it. Now, most of the patients, when we give Depot, as soon as they get amenorrhea, they are very much scared that they had already become pregnant. Even whatever may be the age, they will come and complain to you that I have got amenorrhea. So it is our turn as gynecologists. You should clearly counsel them and give them the details. Of course, most of them, they don't turn, but they go to some other obstetrician, gynecologist, telling that they have got amenorrhea and intermenstrual spotting is also there now. So it is our duty to clearly
this
counsel
patient,
them and give them the consent.
see, now that she's had 12 months of Gnrh agonist, probably I would repeat a scan or an MRI, see how the adenomyosis is doing at the moment. And then if it is still there, she might benefit if she does not want to get her uterus removed. Because if she has to get her uterus removed, she has to remove the ovaries also only, then that would help. Probably she can benefit from endometrial ablation, like a total TCRE. That might help. If you can take out a layer of endometrium with a little bit of the myometrium, that might help her.
When will you decide for a hysterectomy in such patients, multiparous women?
patient is, after a very detailed counseling of all your medical management options like oral progesterones or whatever Dr. Deepa said, and Marina, if the patient is not at all willing for the follow-up or this thing, in spite of a detailed counseling of all plus and minuses, if the patient is requesting, then you are left with no choice for a hysterectomy. But at this point of moment, if the patient is willing to preserve the uterus, I think we can consider Marina if the patient is willing, or oral progesterone therapy.
Yes.
For this particular patient.
Yeah. Siddharth, what is your opinion on LAVH for this patient?
Yeah, frankly speaking, I don't see the gynaec part anymore, ma'am, because I've seen it only probably 8 years back. Maybe in this patient, the pain is intractable with all the medications. What has been, all the medical management has failed, and the pain keeps on coming back on and off, and patient is not comfortable. Maybe. But
there is no point in doing.
You ask me the standard of practice. I should accept my ignorance about it.
So this is the most common type of patient which is seen in the routine OBG clinic, where they come with menorrhagia and chronic pelvic pain. So that is when quick decisions are taken. So we see them in a different angle when we see in a fertility perspective thing, when we think about the agonist and down regulation and stimulation and AMH and everything. So that is a different thing. But when they come for pain, we don't have much choice than to work in between oral contraceptive pills, Dynogest, Letrozole. And
can I add a point?
Is only agonist. So this is what we jumble with, because all these are associated conditions: endometriosis, fibroid, and adenomyosis. Whatever is applicable for endometriosis, 3/4 of it definitely will be applicable for adenomyosis. And the same thing goes, except that we do a normal myomectomy for fibroid. So we are only juggling with what we already use for the other conditions. So it also is also a little bit limited with the treatment that is available exclusively for adenomyosis. So
can I just add a point?
Yeah.
If finally if she decides for a hysterectomy, there is no point in removing the uterus alone.
Yeah,
because adenomyosis per se can increase your chance of getting an ovarian cancer. There are multiple papers. So
we have to remove the source of estrogen. So
exactly, you have to remove
the ovaries. No point in just removing the uterus. So, and the same type, when we see women who are in the borderline age, in the advanced maternal age between 35 to 38, when they have diffuse adenomyosis, then comes the whole problem of implantation failure. We obviously don't have a major reason other than adenomyosis. Down regulation has been done and embryo transfer has been done and pain has been controlled with this, but still it doesn't work. So then the question is whether you want to control the pain or you want fertility treatment. Then we decide and take whichever direction we go. Ma'am, you have any inputs? Dr. Amala, ma'am?
Regarding the hysterectomy,
patients there with pain and adenomyosis, or it is just an incidental complaint which they say?
The question is not so audible for me now.
Do you see pain as
can you repeat? Can you repeat the question?
To add a comment. Deepa.
Sorry, I didn't hear you.
Deepa, you wanted to say something. I thought you wanted to make a comment.
I did.
The question is not audible for me clearly.
Dr. Indumati, what was the final question?
Final question was, I was asking Dr. Amala, how is it there? Do you see patients with a predominant symptom of pain and adenomyosis, or it is just an incidental complaint that they say when they come for treatment? I mean, anybody else can share also, because I don't find pain as the main, complaint when they come for to the clinic or to the fertility clinic. Again, they mask the pain when it comes to fertility because they want desperately the baby. So they don't talk about pain at all. So actually, she must be having a hell of a pain, but she doesn't express that. That's what I feel. So I'm just asking your experience on that. Is it like that?
Most of the time, we are seeing
that is
patients
the
with
same thing.
concurrent.
At any cost, they want to have a baby, no?
Yeah,
Even if
they do
got a
not
malignancy,
tell about the
they
pain.
want to
I
have a
always
baby.
feel
That is the Indians' scenario. Because
Yeah, that is the
without baby,
attitude
they
they
are
have.
not respected in the family. So baby is the first thing for them. They are ready to undergo any amount of torture or any amount of investigation, any amount of surgery to get a baby. So that is the thing for our Indian women. So that is the first choice for them.
That is why I feel that the area of pain has not been explored much in adenomyosis, because adenomyosis basically forms about 40 to 50% of fertility. So when they come for fertility, fertility is given undue importance and the pain is vanished in that. So that is why they keep giving this Dynogest and these pills only temporarily, but the final outcome is fertility for them. So pain as such, I have a very soft corner for them when they have pain and adenomyosis. So I try to treat them and counsel them and give the importance to pain as well. And then once they are convinced about the condition, what they have and how untreatable that is in certain circumstances, then I counsel them for fertility treatment.
If I can add a comment. So actually during COVID, one of these adenomyosis patients was going through hell. Every other month she was suffering with pain. Already adenomyomectomy done, already 2 cycles of ICSI had failed. She was just around 38 years of age. And she didn't have the resources to pursue aggressive fertility treatment. So the number of visits she had for pain management was so much that I opened up the topic of hysterectomy. The couple were going through it for almost 6 months. Finally, they registered in an adoption center and they came forward to hysterectomy. And there is a humongous change in the quality of life. I think that's also something we have to open up at a particular point.
For it. Then only they will tell about the pain. Okay. They may not have that much belief.
Earlier also, somebody asked earlier if we have done hysterectomy for patients with infertility and very symptomatic adenomyosis. I have done for around 3 patients in the past 5 years. All of them were like they had all taken the treatment, IVF failures, severely suffering with menorrhagia. All of them were anemic with multiple transfusions of either iron, lot of pain medication, daily pain medication. I had to encourage them to have a hysterectomy because they are done with all the treatment for pain as well as fertility. 2 of them have adopted, and 1 of them remains the same after hysterectomy.
So that is all. We have the slides for discussion. I would like to thank all the panelists for taking the time to come and attend this webinar. I also would like to thank Dr. Priya immensely for giving me an opportunity today. And I hope to see you all in the conference in the weekend. Kindly all of you attend. Thank you so much.
Thank you so much for doing the adenomyosis module 1 successfully. For all the participants, the speakers and the panelists, I must say we started thinking aggressively right from pain management to up to giving the relief of hysterectomy. I mean, I think we openly talked about it, even if it was a concern of and I must say, my moderators initially deviated, then they brought back the panel on track, and my panelists gave tremendous contribution on the various combo drugs which can be used for pain management. A special thanks for IFS South Tamil Nadu chapter, Dr. Ramani Devi and Dr. Selva Priya, agreeing to put this program on a regular basis. And I think we should look forward on 28th April to the part 2 module. So to bring in more light on this particular topic, adenomyosis, which troubles as much the doctor as it troubles the patient. And of course, a warm invitation on April 23rd and 24th at Hilton Hotel. We are having a committed IFS Tamil Nadu conference, a physical conference. So dress up, let's smile, let's dine, and let's get more academic inputs into us. So thank you so much. And I guess we finished around 6:10 p.m. I was a little apprehensive we're going to go overboard. 10 minutes overboard is okay. So thank you so much to each and every one of you.
Thank you, Dr. Raj.
Thank you.
Priya, nice meeting you.
Chitrakala, if we are out of the panelists, out of the delegates, can we take picture? Can all of us?
Yeah, that's a good idea. Yeah.
Can I request all of you, Dr. Ramani ma'am, Dr. Rekha, Dr. Selva Priya, to just come video on, please. Sport a good smile. Most of the time when all of us are talking, some bizarre poses are caught, right? So I guess consciously we pose and we have one good memory of today's program. So Chitrakala, just 1, 2, 3 and click, please. Chitrakala.
I think Deepa has clicked.
Yeah, some.
Yeah.
Anyone from Deepa out there?
Deepa got it.
Okay, Deepa got it. Then maybe I was talking all the while. So someone maybe.
I've taken a screenshot also. I'll send it to you.
You should have said 1, 2, 3. I was going blah blah blah.
Okay, now 1, 2, 3. Smile, everybody. Okay, done.
Thank you so much.
Thank you, Dr. Deepa.
Done. Thank you. See you all on Saturday.
Okay.
Thank you. Thank you. Thank you, everybody.
Thank you so much. Thank you, Amala ma'am.
Thank you.
தெரியல அது நம்ம முதல்ல கேட்டுக்கிடும் சின்ன பிள்ளைங்களோட எல்லாம் சின்ன பிள்ளைங்களா இருக்கும் ஒரு ஆளுதான் சீனியர் ஸ்கிரீன்ஷாட்டா அவங்க அனுப்புவாங்க பாரு இதுல எப்படி இருக்கு இல்ல இதுல பாரு எல்லாம் இப்ப படிக்கிற பிள்ளைங்கள என்னமா இருந்தாலும் வந்திருக்கா அனுப்பி விட்டேன் எப்படியும் முடிச்சுட்டேன் ஒரு வழியா இல்ல இவங்க எல்லாம் இப்ப படிச்சுட்டு இருக்காங்க இவங்கெல்லாம் வந்து இவங்க சின்ன பிள்ளைங்களா இப்ப படிச்ச பிள்ளைங்களா கட 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 இந்த டிஎன்எஃப்க்கு வேற பணம் அனுப்பணும் மொத்தம் இன்னைக்கு இந்த பிள்ளைகள் இதை பணம் கொண்டு வந்து கொடுச்சப்பா யாரோ ஒரு பொண்ணு கொடுக்குறேன்னு விஜயா என்ன போட்டு தொந்தரவு பண்ணிக்கிட்டே இருந்தது இது என் கிளாஸ்மேட் என்னமா என் கிளாஸ்மேட் நம்ம மேக்கப் போட்டு அப்படியே தரமா அப்ப